drivers. But we're going to first dive into the numbers of new cases. So you will see that we have segmented the numbers by gender, and also, just to make sure that we don't forget the children, you also see that about 12% of children do get TB annually. And again, when you look back at the numbers over the last 5 years or so, the numbers have been consistent globally. Of note here, of course, is that you see that adult men somehow take the lion's share when it comes to the TB burden. And when again you look at the deaths from TB, you still see that whether you look at HIV positives or HIV negatives, men still take the lion's share, both in burden and deaths globally. And of course, for people who have been around in the world of looking at TB prevalence data, you will notice that when you look at the numbers actually of people who show up for screening, men represent about 30%, and yet they still take the lion's share of the TB burden, both mortality and morbidity. So when it comes to presentation, men still will present with more severe forms of TB. So the picture you see down there is very typical for people who have been on the wards. And we have had these discussions that as long as a man wakes up in the morning and they can walk to work, you will not see them in the hospital. And that even when the wife clearly tells them that please pass by the hospital on your way to work, it will end in frustration. So typically what you will see when you find a man in hospital, when you look behind, the wife will not be so far. And when you ask them why they are in hospital, they will tell you, it is the woman who has brought me. And when you ask the women why they have brought him, the woman will start complaining of all these things, the fevers and everything. My husband is wasting away. And the man will defend himself and say, but she's exaggerating things. And you will have that very heated conversation in a consultation room. So you will typically find men coming down with more advanced symptoms of TB. Hemoptysis tends to be quite advanced. And sometimes when you find someone who has hemoptysis, it somehow gives you a picture of the extent of damage in the lungs. So I'm going to show you an X-ray of a patient I saw early this year, a male patient who presented. And this was his X-ray. Now, we are not going to do any lessons on how to read X-rays. But when you look at that X-ray, you totally see that one part of the lung is white, while the other is black. So even if you've never seen an X-ray, you will definitely know that one of those, either the black or the white, is abnormal. But I'll simplify work for you. The white part is the abnormal one. And you will see the extensive damage on the X-ray, on the chest. And this, again, for people who are in the TB world, is not new. It is something that we see all the time. Now, these complications, I need to emphasize here that, of course, once you pick that patient, you will be excited to quickly take them out of saturation in public. So you will do a gene expert, diagnose them with TB, and start them on TB treatment immediately and make sure that they adhere to their treatment. And at the end of the 6 months, they will come back and thank you for insisting that they take medicines, because now they feel better, they've added weight, and they feel like they've gone back to their normal life. But what will not go away is all the white part that you saw on the X-ray. So that damage remains permanently. And when you look at the descriptions that have been described in literature after TB, these are just some of the complications that are included on the slide to make it readable. If we are to include everything, they will be so tiny you won't be able to read. We have not included the musculoskeletal complications. So for people who get TB of the bone, you'll find that they still get some bit of abnormalities. They need some bit of support, sometimes even surgery. But there are so many, from basically every part of the lung, from the parts of the pleura to the parts of the lung parenchyma to the parts of the airways. Those become permanent radiological abnormalities. And I'm going to share with you some of the x-rays of our patients who participated in this trial, and you will see what I'm talking about. So you see that. You still see that one part of one half is too white. And as we've discussed, that when you see white, it means bad news. So you see again quite extensive damage on one part of the lung. Again, you see that if we were to go through, we could probably list even more than what I highlighted in the slides as complications of TB treatment. So these are patients who are happy that they completed TB treatment. But you can see, we had a discussion here with the patients, and we told them that at the start of TB treatment, if your lungs were at 100%, by the time you finish it, your lungs actually, you will have lost quite a number of units, lung units, that some people even go as low as 50%, 40%. And as we will see, this tends to make life a bit more complicated. So the x-rays continue, just to show again the extent of damage. And what you see here are the various clinical syndromes after TB treatment. So these are the post-TB syndromes. Now, when a patient comes to the clinic, this is something that people do not know. Most of the time when people show up in the clinic, I think if you were here when Professor Bruce was giving his opening remarks, he told you about how many rounds TB patients get of anti-TBs. And it's because they show up coughing. And if you're coughing and you go to a place that has plenty of anti-TBs, you will get a round of anti-TBs, because that is the easiest way of somehow getting you out of the consultation room. And it's the same thing when you go to other places where they don't have anti-TBs. They will give you antibiotics, cough syrups, and things like that. But what you actually have, and yesterday actually when we were in this room, we disseminated our findings to the participants who participated in the trial. And at the end of the day, we had an interaction. And they reported some of the things that are still bothering them, and they were all here. And I showed them this slide to show them about the different clinical syndromes that developed after TB. So basically, when a patient comes up and you establish the fact that they've recovered from TB, you need to evaluate them for any of them. So just because they have cough and chest pain doesn't mean that it is because of the scars. You still have to go ahead and evaluate them to the best of your diagnostic capability in your clinical unit. Now, we dive into the background of PTLD. I had already mentioned that when you look back for the last 5 years, these numbers are consistent. And globally, right now, as of 2022, about 2 years ago, an approximate 155 million TB survivors were alive globally, with about 25 million living in sub-Saharan Africa. And with everything that you have seen, I don't have to emphasize the point that post-TB lung disease is a big problem. However, I think you've seen with all the clinical syndromes, yeah, you can give someone an inhaler and things like that, but there is no medicine currently that reverses the disability associated with post-TB lung disease. We have seen, even from Professor Sally's presentation, that pulmonary rehabilitation has been shown to be highly efficacious in chronic respiratory diseases like COPD. Highly efficacious, so much that you can no longer receive funding to conduct a clinical trial of pulmonary rehabilitation in COPD. The evidence is now overwhelming. And although it has also been tried out in a number of chronic respiratory diseases, its evidence, the evidence of pulmonary rehabilitation in post-TB lung disease is largely unknown. And I think, again, you probably had Professor Sally when she was discussing about the current evidence that really no clinical trials, no high-quality clinical trials had been conducted. So we set out, we conducted this clinical trial to determine if pulmonary rehabilitation compared with usual care improves exercise capacity measured by walking distance on the incremental short walk test in adults living with post-TB lung disease. The other objective was we wanted actually to find out if this program was cost-effective as well. So now we dive in. So this was a a single center randomized clinical trial with blinded outcome measures. And we included adults aged 18 years and above with a definite past history of pulmonary TB. So we needed to see confirmation either on smear or culture and on sputum. So it had to be past history of smear positive pulmonary TB. And they should also have presented with breathlessness as a symptom, reaching an MRC dyspnea grade of at least 2 or more. They also should have had an X-ray, so we also did X-rays for all of them, and they should have had an X-ray that was consistent with post-TB lung damage. We excluded all those who, for one reason or another, could not participate in exercises because exercise was the main drug for these patients. So the study was conducted at the Lung Institute. For those who have been at the premises, that small building there is not new to your eyes. That's where it's actually our rehabilitation house, and that's actually where the clinical trial was conducted. So everyone who was coming to the hospital for hospital-based pulmonary rehabilitation enjoyed exercises in that room. Participants were randomized using a web-based randomization system in a ratio of 1:1 to either receive pulmonary rehabilitation or usual care. Our primary outcome of interest was change in walking distance measured by the incremental shuttle walk test. If you look back behind this room, you will see those two cones. They are to demonstrate to you what the incremental shuttle walk test looks like. They are not stretched out because they need about 10 meters, and if we were to stretch out the entire cone, it would have gone up to probably where the cameras are. But that's really to demonstrate to you what the standard length of an incremental shuttle walk test looks like. We set the minimal clinically important difference in this trial at 35 meters, and this was extrapolated from the COPD population. And this was to represent a group improvement in walking distance after the post-PR shuttle. So at the end of the rehabilitation, they conducted another incremental shuttle walk test, and the difference between the baseline and the follow-up should have been at least 35 meters for the entire group that was offered the intervention. Sample size, sample size was calculated, and we required a total of 114 participants to detect the 35 meters that we had set as a important clinical difference in the trial, and that the sample size of 114 would also will be able to detect the 35 meters as both clinically important and statistically also important. And down there, we really go through the rigors of what we did to estimate the power calculation, including, so we used a previous pilot that we had done at the Lung Institute, and I think, again, if you're here, when Professor Chirenga was giving his opening remarks, he mentioned about the work that we have been doing over the last 10 to 15 years. And so we started out with a pilot study that demonstrated remarkable improvement of pulmonary rehabilitation in the post-TB population. So that's actually what we used to power. So just again to mention that when you compare with all the studies that were available, that small pilot we did had the biggest sample size, even though it was, again, low quality. So, and that's why we used to measure the power. And we set with different triggers, as you know, p-value of 5%, statistical power of 80%, and we estimated the losses to follow up to be about 30. So we needed absolute numbers of 40 in each arm, at least 40 in each arm, to be able to analyze the power in, the study powerfully, meaning that we would have detected the differences to be statistically significant. So we had two randomization arms. So participants were randomized to either receive pulmonary rehabilitation or usual care. So usual care really is inhalational therapies, as we saw among the so many syndromes. We did spirometries for these people, and anyone we detected to either have had COPD or asthma was given inhalational therapies as appropriate. For those who were smoking, we offered them brief advice to stop smoking. And for those who were exposed to biomass, we advised them on ways of reducing exposure. Now, the intervention was designed according to international guidance. So we offered sessions twice a week for a total of 6 weeks. That makes them 12 sessions. Each session lasted 2 hours, including 1 hour of exercises and 1 hour of education. So right there in the corner up there is an education session going on. And then what you see are some of the exercise sessions that we did for this trial. So just to take you through the different stations. So I think, again, when Professor Sally was up here, she mentioned 2 types of exercises: endurance exercises and muscle strengthening exercises. So here you see our stations. So there are 6 stations in total. 2 stations are for endurance exercises, and that's really for cardiovascular training. And you see that most of them are going to make you breathe very hard after participating in them. So that includes either cycling, and that cycle is a stationary cycle that is load resistant, so you can actually increase the load. You want the patient to exert themselves properly to a level where they are properly breathless. That's when you know that now I think this dose of exercise is adequate. And then the walking station is really a station outside where the patient again walks at a steady, fast pace until when they feel breathless. So that's part of the cardiovascular training. Then you have muscle strengthening exercises. There are 4. 2 of them target the upper limbs, and 2 of them target the lower limbs. And you may wonder why exactly that is. So we have put for you some stations down there to actually appreciate what exactly it means when you are strengthening the muscles. So these are muscles, and again, from what Professor Sally was saying, a fit muscle consumes little oxygen. And that's why, so we do not do any magic. We don't transplant lungs. We don't add you any lung volume. But we make sure that, so the exercises are aimed at making sure that that little oxygen that you breathe in is more than enough for you. In other words, if you woke up in the morning and you discovered that you do not have water in your tank, but there is a small 5-liter jerry can that you have somewhere that has water, you will be surprised. That water will be enough for you to brush your teeth, to take a complete shower, and still remain with enough water to prepare tea and drinking water with just 5 liters. And yet when you have plenty of water, you can bathe 100 liters in just one go. So that's basically what the essence is, that little oxygen that you breathe should be enough for you to actually to go about your activities of daily living. So that's where the muscle strengthening exercises are supposed to do. So the two exercises for the upper limbs, when you actually when you look at those muscles that are being strengthened, they are the muscles that you use for your daily activities. Lifting up, so bathing, lifting up. So when you talk to patients with chronic lung disease, they will tell you that they get issues even with simple exercises like bathing themselves or even scrubbing themselves. And it's because those are the muscles that are very unfit, So and that's what we are trying to do to reverse that deconditioning. So those are the exercises, and you can see the different stations. We have some weights there. Please, before the end of the day, make sure that you've appreciated each of the session, just to know that these things work. They will probably make your muscles hurt a bit if you do them properly. You remember when Professor Sally again said, prescribed? Yeah, we prescribe your dose according to your fitness. Then we just increase your load a bit. So yeah, so if you do it properly, you'll actually feel the effect in the muscles. All right, so let's now dive into the results. So between November 2020, I think you remember 2020 was a very COVID year, all the way up to 30th September 2022. Those 2 years were really COVID years, and I think that's also something that Professor Sally said. That's actually when the study took place, so you can also imagine some of the challenges we got, that those lockdowns did affect the study as well. So we had to be stopping the study and then opening again when the lockdowns are lifted. So we screened a total of 178 participants to eventually randomize. You remember our sample size, 114? So we needed to screen 178 participants to get a desired sample size of 114. Using a web-based randomization system, each arm received 57 participants. One of the things I want you to probably appreciate here, is that in the intervention arm, which is really the rehabilitation, of the 57 that were randomized to receive pulmonary rehabilitation, 48 came back for rehabilitation. And the adherence, so when you look at those who met the adherence threshold of adequate exercise training were 41. And that represents around 72% of adherence to the program. Now, when you compare in literature, this is way above what you see in high-income countries. Most of the adherence in high-income countries ranges between 40 to 50 there. So adherence in this population was very high. Right. So now, when you look at the baseline characteristics, again you see more males, which is not very surprising given the burden of disease amongst the males. So more males were enrolled in this study, but you can see how young these people are. 43 years is probably the peak of your productivity. That's really when you make the money that your family will appreciate. And that's actually where most of these participants were. When you look at HIV, surprisingly, I'm saying surprisingly because it's actually quite high. We know that TB is highly associated with HIV in our settings, but in other settings, actually, HIV is unheard of. So this actually is quite new, having about 25% of the population having HIV. But you can also see that although these are people who are supposed to be highly productive, I don't know what has happened. But I think they're going to yeah, so what I'm trying to say is that, okay, very good. Yeah, so you can actually see here that about 45% of these people were unemployed. And again, we were discussing this with participants who were in this room, that for example, if your work is to be at the construction site as a mason, where you're supposed to be carrying things, the foreman at the site wants people who are highly productive, people who will work from 8 to 7 p.m. That is good return on the investment. But when they realize that they're hiring you, but you start at 8 and you're tired by 11, and then you find a way of dodging around until the end of the day, you probably will not get a job again. And it's really because of everything that we have seen as a complication of post-TB lung disease. Then the other thing that also you notice here, you see that only 30% had normal spirometry. And again, that alludes to the earlier table that we were talking about, the clinical syndromes of post-TB lung disease. So you see that only 30% of this study population actually had normal spirometry. So this is the analysis of the primary outcome. So we did a generalized linear model analysis of the primary efficacy outcome at 6 weeks follow-up. So this is at the end of pulmonary rehabilitation. So all participants who were in both arms repeated the incremental shuttle walk test. And after adjusting for baseline characteristics that significantly differed between the two arms, participants in the pulmonary rehabilitation arm registered improvements of walking of 53 meters compared to usual care. Now remember that we had set our minimal clinically important difference at 35 meters. These reached 53 meters, way above the MCID. And this was both clinically important and statistically significant, as you can see, the narrow confidence intervals and the significant p-values. So again, showing how effective pulmonary rehabilitation was in improving exercise capacity in these participants. When we looked at the secondary outcomes, we did a difference in difference analysis. And maybe just to simplify this, so it's you use a complex statistical term. And what it will do, it will go in the data and measure the difference between baseline and 6 weeks in both arms. So it will now pick that difference, then compare that difference between the two arms and see, is this difference very different between the two arms. So that's what we call a difference in difference analysis. And when that was done, participants in the intervention, the pulmonary rehabilitation arm, registered improvements in, remember when you talked about breathlessness reaching MRC dyspnea grade of 2 or more? So this is what actually we see. So participants in the rehabilitation arm improved in terms of breathlessness using the MRC dyspnea grade. And then, so the CAT score and the CCQ score measure symptoms, respiratory symptoms, cough, difficulty in breathing, and all those things. And again, you see that participants in the pulmonary rehabilitation registered reduction in improvement. And that was, again, significant between the two arms. So you saw that the intervention, which is pulmonary rehabilitation, improved patient symptoms and increased their, and reduced also their breathlessness. I think it's better to stick to reduction, because when you say increase and decrease, then you don't know which one is increasing. But here you see that generally a reduction in breathlessness and a reduction in symptoms in the pulmonary rehabilitation arm compared to the usual care arm. Okay, so this is just a summary slide. I probably will not go into this because this is our next presentation, the cost-benefit analysis of the program. But just to summarize for you that just in case you step out when the conclusion is presented in the next presentation, that the cost-benefit analysis actually was found to be, the program was found to be cost-benefit according to, sorry, not cost-benefit. So based on the average QALYs gained from the calculations, the average cost of the PR program was about $6,446 dollars per QALY gained. And when you look at NICE's grading of cost effectiveness, it actually shows that this program was cost effective. So our conclusion here is that in a young study population with disability associated with post-TB lung disease, our 6-week PR program elicited clinically and cost-effective improvements in exercise capacity and health-related quality of life compared to usual care. That is my concluding slide. Thank you. So you please keep noting your questions. We will address them at the end. So I'll just confirm, but our next presenter is presenting from the UK. So I'm going to just briefly walk behind to make sure that he is on and ready to take us through the presentation of the cost-benefit analysis.
Thank you, Wisi, for the elaborate findings we reached at during that recharge project. And I believe that if I give you how my first initial interaction with the pulmonary rehabilitation was that you know, we know what chest physiotherapy, as has been mentioned before. And even up to now, still they write chest physiotherapy. But Pulmonary Hub is a package that gives a lot of differences, as results have indicated there. And there's nothing good in life that somebody comes stressed, depressed, which issues I think here Winston talks about radiological findings, but there's social, psychosocial issues. And I think also those they take them, the patients badly off track. Because if you are trying to look for money for your family and you can't, and the demands keep coming on your table, I don't think you can be happy where you are. So there are many psychosocial issues which through education and empowerment and going through the program, that the participants were very happy of at the end of the program. It works for them. We had a question here yesterday that the syrup and exercise, which was better. I wish you would hear what their answer was. If a syrup and exercise which worked for you, you would be amazed to, if the recording was done, they would tell you what they mentioned. They were saying exercise. So now, I just pray that as we get on, as we wait for the next presenter, that this intervention is taken on as we, since the director was here, Representative Director General, and NTLP program and other policymakers are here, we look forward that we help our community and our people who have suffered post-Bilanga disease. Wincy, are we ready? Okay, thank you. Next, we are having some colleagues online, and here we are going to see the recharge economics analysis, looking also at quality of life and productivity for those that underwent through the program. Here we welcome Professor Jesse Matheson, School of Economics, University of Sheffield, that's going to give us the feedback from Professor. Jesse, you are welcome. Take over, please. Thank you.
Thank you very much. Can I just confirm that you can see my slides and everybody can hear me okay?
You are audible.
Terrific. Okay, so my name is Jesse Matheson. I'm a professor of economics at the University of Sheffield. And I've been working along with Wincy on the cost-benefit analysis that goes along with this program. So, okay, so what I want to do, what I'm going to walk you through here is how we did the cost-benefit analysis and the main outcomes that we're interested in. So there's going to be three different outcomes that we're interested in with this particular analysis. So the first is going to have to do with quality of life outcomes. So we conducted a survey in which we solicited different quality of life outcomes for the recipients. And we can look at the difference between treatment and control before and after the program. We're then going to use those quality of life outcomes to calculate what Wincy just mentioned was what's known as a quality adjusted life year, or a QALY. And this QALY is going to be very useful for us because we can use this QALY to come up with a single measure that allows us to not just think about the effectiveness of this program itself, but also to compare it to other programs for which we might be competing for funds with, for example. So we can say something about, is this program actually good value for money? And then finally, and this is one of the, I think, novel contributions of the way we've approached the cost-benefit analysis here, is we're also going to look at measures of productivity, both at work and in the home. And this is going to give us a really tangible measure that both patients and policymakers can understand. Because a quality adjusted life year is a fairly abstract concept, but how many hours a week you're able to work is something very concrete that everyone can understand. Okay, so, and that brings me to the benefits of doing a cost-benefit analysis, is there's both going to be tangible benefits for the patients themselves in trying to help the patients understand why they would want to go through something like a pulmonary rehabilitation program. So for example, we're going to come up with numbers that allow us to say pulmonary rehabilitation leads to an increase of X hours per week in the average patient, or patients see a decrease, an X% decrease in their reliance on family members in helping them with day-to-day tasks. But then also, I mean, we're all probably going to be competing for public support for programs like this. And there's lots of different programs that public funds could be used to support. So for this reason, we need to be able to show that first of all, the benefits to the program outweigh the costs of the program. And the program actually leads to better improvements than other competing programs that might also be going for the same pool of funds. Okay, so I'm going to start with the quality of life outcomes. I'm going to walk you through what we looked at. I'm going to show you a few of the outcomes. We won't go through everything. And then from here, we'll start to look at, well, how do we go from this quality of life survey into calculating quality adjusted life years. Okay, so we took advantage of the European Quality of Life 5-dimensional questionnaire. So this looked at 5 dimensions of quality of life, as the name would have you believe. So we looked at mobility, so your ability to get around, your ability to look after yourself, self-care, your ability to conduct your usual activities, so whether that be in the home or the workplace, the amount of pain and discomfort that you're regularly experiencing, and finally, your experience of anxiety or depression. And the way this questionnaire was structured, so I'll just look at an example for mobility. So it would ask you which of the following describes your day-to-day situation. I have no problems walking about. I have slight problems walking about, all the way to I'm unable to walk about. So a score of 1 for each of the 5 dimensions means that you're in the best state. So you have, in this example, no problem getting around. A score of 5 means you're in the worst state. So a higher score is bad in this case. Okay, so just to give you an idea of what these look like. So in this figure, I'm showing the number of patients across the intervention and control group at assessment and at the 6-week assessment, at the initial assessment and the 6-week assessment, who reported they did not have any mobility problems. So they reported a 1. And we can see from this figure, so the intervention group, which is shown by the orange line, is increasing fairly dramatically over this period. So it goes from about 55% of patients reporting that they did not have any mobility problems to almost 80%. But we see very, very little change for the control group. Similarly, we can look at the same thing so this is for self-care, the ability to look after yourself, which for a lot of these patients is going to be one of the critical things that they're interested in. And we see a change, again, an increase from 80% to just over 90. I think that's about 93% of intervention group patients reporting that they don't have any problems with self-care. And this is a statistically significant increase over and above what we see for the control group. Okay, now we can take these measures, so these 5 different outcomes that we're interested in, and we can put them together in what's called a quality adjusted life year. So looking at the different outcomes by themselves is interesting, but it's hard to say, I mean, is this really a significant change in quality of life overall for these patients? And that's what a quality adjusted life year is meant to give us. Okay. So I'm going to walk you through how we calculate the quality adjusted life year. So first of all, we're going to calculate a score based on each subject according to how they answered the questionnaire. We then assign a quality index value to each score. Now these quality index values, these are calculated in different studies. They've been vetted, so they're internationally used standards of a quality index. And then, so that gives us a quality index, which is going to allow us to compute an average treatment effect. So we can look at the difference between the treatment group and the control group in how their quality score changed. This is the difference in difference analysis, which Wincy just told us about. Okay, so I'm just going to walk you through a fictional example of how we might do this calculation. So here's our 5 criteria listed, and here's a fictional scoring of the criteria. So this would be a patient who's in a fairly bad state. So a mobility score of 3, self-care score of 3, usual activities is 4, so they have a lot of trouble with their usual activities, pain and discomfort 2, and anxiety of 3. So what we do is we bring all of these numbers together in a single score, just putting them sequentially in order. Okay? This score is then linked to a quality index value through a standardized linking that, this is readily available online and has been done through other studies. So in this particular case, this score based on the questionnaire would have a quality index value of 0.433. So this roughly means that the quality of life this person experiences is about the same as somebody with perfect life only getting about 43% of a year. Okay? So significantly lower quality of life overall than somebody relative to somebody with a perfect life. So this quality index has a maximum value of 1. So if you have a value of 1, you're in absolutely perfect health. If you have a value of 0, this implies that your life is essentially equivalent to being dead for the most part. But importantly, this can actually take a value of less than 0. So it is possible to have a score where your your quality of life is worse than being dead. Now, nobody in our study is even close to that. Everybody in our study has a reasonably high quality of life compared to 0. Okay, now to give you an idea, so here is the difference in difference analysis for the quality score, which Wincy talked about. So the average subject has a quality score of 0.82 in treatment at the initial assessment. And that's the same for the treatment and the control group. Now that increases for both groups, but it increases significantly more for the treatment group. So the treatment group experienced an improvement that was 0.018 points larger than the control group. Now, to give you an idea of what this means, it means, roughly speaking, this would be equivalent to an otherwise healthy person experiencing some slight pain and discomfort throughout the day. So that's how big that difference is. Okay? Okay, now, so we have this quality measure, and we can see that it's differing between the treatment and control group. But it's still, we don't have a way of saying, well, is that a big difference? Is this a good program? And that's what the cost effectiveness analysis is going to give us. So we're going to do a calculation of what's the cost for every quality adjusted life year that's gained in this program. Okay? And so to do that, what we're going to need to do is we're going to need to compute the cost of the program per patient and then look at the average quality gain per patient of this 0.018. Okay, so here's just a high-level view of the program costs for the pulmonary rehabilitation. So this total is the total for the entire time the program was running. Now, if we then divide that by the number of patients that we were able to put through the program, it works out to be a cost of about 114. So this is in US dollars per patient who is put through the program. And this is a comparable cost to other programs we've done, for example, in Kyrgyzstan. Okay, now we can use this number to calculate the cost per quality. So it costs $114 per patient, and each patient on average gained 0.018 QALYs. So this works out to be a cost per QALY of almost 6,500 US dollars. Now we want to do one more adjustment here, and that's for the fact that the purchasing power, because we're going to compare this to UK level cutoffs for a QALY score. What's cost effective from a UK standpoint? Now, of course, purchasing power in the UK and the US is very different than it is in Uganda. So $1 buys you more in Uganda than it does in the US or the UK, meaning $1 is more valuable. So we want to adjust for those purchasing power differences. And when we do that, we work out with a value of roughly $20,000 per QALY in US purchasing power. Now, this is still comfortably within the NICE guidelines for the UK guidelines for what a cost-effective program is. So those guidelines say a cost-effective program should fall somewhere below 25,000 or 25 to 38,000 US dollars. Okay, so this is a cost-effective program by those measures. Okay, so in terms of quality of life outcomes, this is a cost-effective program. It's something that should be funded, or something that NICE would recommend for funding. But now we're going to turn our attention to some of the productivity outcomes that we looked at. So productivity both in the workplace and the home. And these are nice outcomes to look at, because unlike the QALY, which is a fairly abstract thing, these are going to be nice concrete measures. So we used what's called the Worker Productivity and Activity Impairment questionnaire, and we modified this to also include some questions about not just your productivity in the workplace, but your productivity at home as well. So this includes questions like, are you in employment? The hours that you missed because of illness, the hours that you missed for other reasons, illness effect on productivity while working, and a number of different other things. So we took this questionnaire at the initial assessment and at the 6-week point. Okay, to give you an idea of how we're using this questionnaire, so here's another hypothetical example. So I've got assessment and discharge, or the 6-week period, and I have somebody who is in employment, and they're saying that at the initial assessment, they didn't miss any hours because of their illness, they didn't miss work for any other reason, and they worked 48 hours for pay. However, they're reporting that they do have some work impairment. Okay? So they're saying that the effect on work productivity of the illness is about a 2 out of 10. So what does this mean? This means that about 20% of their work is being compromised because of their illness. Okay? So 20% of the time, they're just not working to the standard they would like to be working at. Well, we can take this, we can look at the hours they actually worked and adjust it for the productivity difference because of the illness. So we would say that this worker is working 48 hours, but only 80% of those hours are actually productive work. So it turns out that they're working 38.4 productive hours per week in the initial assessment. Now we can do the same calculation for the discharge period and then calculate the change in productive hours worked over these 2 periods. And we can see in this hypothetical case, so there's no actual effect on their productivity at work, but they are working considerably more hours per week in the discharge period. So we would say this patient experienced an increase of 13.6 productive hours per week. Okay, so that's just a hypothetical example. So there's a number of derived measures that we're using from this form. So there's employment status, of course, lost hours working due to the illness, productivity impairment while working. So that would be going to work but not feeling like you can do your job to the standard you would like to. Overall work for pay impairment, and then impairment in regular household duties. So how much trouble are you having with your work around the house, and reliance on family members to help you with those regular household duties. Okay, so here's the outcomes that we have for these. Now, I should point out right away, most of these outcomes are not showing up as being statistically significant, although they're all moving in kind of what we would think of as the right direction. That is, there's an improvement. Now, where we are seeing a large, significant improvement is in the hours that they're working. So it's not that people are going in this subject pool are going in and out of work. So they're not quitting jobs and going back into jobs. They're continuing to work, but they're working more hours per week. And in fact, this works out to be 5.2 productive hours per week more that's being worked. So if we think about, I mean, what does this mean in real terms for people? So if we think about the average teacher in Uganda, the average teacher's salary, this would be equivalent to the average teacher earning about 92,000 more shillings every month. Okay, so just to wrap things up, so the Recharge program resulted in positive quality of life outcomes. It also was shown to be cost effective by the standard UK NICE threshold. And the Recharge program resulted in positive work-related outcomes. In particular, we see a significant increase in the amount of work people are doing, and this is likely due to just calling in sick, leaving work early, things like this. So I'm going to leave it there. Thank you very much.
Thank you, Professor Jesse, for the economic aspect of how Piara went on in Uganda. And I think all of us will appreciate, and we have the view that since he has presented online, any other person having a question for him, we could have it before he goes, other activities taking off. Any question, please? Professor, are you still online? Any questions, please?
I'll try and compete with the truck across the road. Thank you so much. These are very nice. I can't compete. I've given up. But these are very nice findings, and it's interesting to know that a lot of effort and work has gone into this. I don't know about everyone else, but for me at least I'm convinced now that pulmonary rehabilitation is probably the way to go. But listening to all the presentations, one gets a sense that, and I hope I'm not representing everyone else here, that when you say pulmonary rehabilitation, you're talking about exercise. But I know it's probably much bigger than that. Things around psychosocial support, things around nutritional support. So I would want Wincy to probably tell us, is my assumption right or wrong? And if it is right, in your your analysis, did you try to factor in these? That is one. Two, the incremental shuttle walk test. I'm just interested in knowing why you picked on this and not any other test for exercise tolerance. I would imagine there are others. At least one I know is the 6-minute walk. So why it influenced your choice of this test? And then it's very interesting to learn that there was higher adherence compared to what we see in the high-income countries. By the way, even for our trials, clinical trials, we struggle with cohort retention. But in your cohort, there was quite good adherence. I don't know what you did that we could probably pick. Or is it because majority of your people were not employed? Is it because majority of your participants had HIV, so they are used to this chronic care mode of offering care? So they have no problem coming for those regular interactions with the healthcare system. So I would want to pick this, and for me this is very helpful because I can then take it back to the clinical trials that I'm involved in. I'll stop there, and if there's another opportunity, I'll probably ask other questions. Thank you.
Thank you for the presentation. Please, Doctor.
Let me also add my voice to my colleague and thank the team for very important research and sharing out the significant findings. We've clearly seen and you have demonstrated that pulmonary rehabilitation improves quality of life. My question is, have you observed any survival, what is your survival rate of the people who have had pulmonary rehabilitation? If you have been keen to observe, has it improved survival rate, maybe 5-year survival rate or 10-year survival rate? Number two, what is your take, particularly Wincy, on assessing patients who are taking medicines for pulmonary disability? Do you have to wait for end of treatment and start assessing, or should start assessing these patients on the day they initiate treatment? And if any is found to have a disability, he is rehabilitated. Because I can see your data, most of it is coming at the end of treatment, positive B. Can we have assessments from word go when patients are starting treatment? And maybe we could be able to save some of these patients. Thank you.
Any other question, please?
Thanks to the team for this great study with these good findings. Now it's shown that yes, pulmonary rehabilitation is, like my colleagues have said, is the way to go for such patients. We have human resource constraints in our healthcare system. How do we increase access? What are the answers to accessing pulmonary rehabilitation for these patients? Thank you.
Thank you very much. I just wanted to ask about this cost, which you put at $6,586 as a total cost for quality adjusted life year gained. It involves also other costs like human resource and probably space. Where there is space at, let's say, regional referral hospital where we might not have
syndrome that you noticed in this study, and how would you aggregate it according to age? Who would be the, how would it differ in terms of age and also gender? The other is about if you're to do a similar study among children, what do you anticipate as a physician the most common syndrome would see among children? And also, would you think the children would also benefit from this program, these exercises? Do you think that children can also benefit? I'm referring to those 10 years and below? Do you think they can also benefit? And also, what are your plans of empowering healthcare workers? Because it is a very, very common problem. Some of these people who are managing at lower health facilities, they usually get these issues after treating a patient with TB. They are still having symptoms. How are you going to help them? And also reach out, and how are you going to extend this program to those health facilities? Thank you.
Doctor?
Thank you very much. I think one of my questions has been tackled by the previous questioner, but it's about the age. I don't know whether I try to stratify. You told us the majority were around 40 and below, but I don't know whether there is any significance between the lower age and the elderly people in terms of improving the exercise tolerance. But also I am asking whether we will manage to do some pulmonary function tests in particular, or if there is any role for the pulmonary function as far as the rehabilitation is concerned. Over.
Pass it over to the neighbor in front.
Yes, thank you so much for the wonderful results that have been shared from this study. I have two clarifications I'd like to seek from the presenters. One is I thought through pulmonary rehabilitation there would also be improvement in lung function in terms of the volume and the ability to hold more air. But seems from the presenter, I think Dr. Wincy, you said the role of pulmonary rehabilitation is to improve the muscle strengthening exercise. Maybe I didn't get it very well, but what is the role in terms of improving lung volume and elasticity generally around that improvement? And then secondly, we have a challenge in terms of interpreting chest X-ray abnormalities to distinguish active TB disease from post-TB lung disease. So when you talked of consistency, chest X-ray consistent with post-TB lung disease, I would like to know what are those exact X-ray abnormalities that are consistent, that can be distinguishable from active TB disease, to help the general clinicians who are not at that specialist level, but who are interfaced with these patients through most of the care they provide. I would really seek some guidance around that. Then thirdly, what's the role of adjunct therapy in pulmonary rehabilitation? Apart from the exercise, were there any other medication? I heard about the issue of syrup, but I don't know if there are any other things like steroids or any other form of chemotherapy that can also help to relieve the recovery of these patients. Thank you so much.
Yes, my question is for Professor Matheson. So I was just wondering about using the NICE threshold. I was just wondering if it would be of benefit to consider other thresholds. I know that GDP per capita threshold has issues, but when we look at other studies that have tried to assess thresholds for a country like Uganda, they still end up comparing them to the GDP per capita. And looking at GDP per capita, if we put those results in that context, what would be your conclusions on the cost effectiveness? The second that I have is if you incorporated indirect costs, because you in your the last couple of slides there was a discussion on improvement in work productivity. So are these societal benefits and all of these indirect costs included? And probably the last is any benefit in extrapolating these benefits over time, because I don't know if Wincy covered this, how long does the PR program take? And if patients actually do exit from this program and end up carrying on these benefits over their lifetime, what would be your thoughts on extrapolating this and the wider cost effectiveness of PR programs?
You.
Yeah, so my question was in terms of the perspective, which perspective did we take? If it was societal, did we consider the healthcare associated perspective? And also, if yes, what are some of the key implications for policy? Thank you.
This might go to Wincy, basically on the programmatic side. Now, I probably missed the first few minutes of your presentation, but I would like to understand in the patients you enrolled, according to your outcomes, is there a particular cutoff, let's say examining the patients and correlating them to the kind of patients we have in Uganda, that is there a particular cutoff that you would say these ones would benefit from the rehabilitation program, and so that we are able to prioritize such kind of patients, because we have very many who might need, in view of the need, that kind of suggestion would be very good for us to know. Thank you.
Thank you.
Thank you for the wonderful presentations. My question is about accessibility to the to this pulmonary rehabilitation, and whether it is what your thoughts are of bringing these services closer to the community, because we understand that there are challenges of transport to go to the facility, both in terms of transport and of time. What are your thoughts about bringing such services closer to community? Thank you.
Thank you. Any other question for the professor? Thank you for wonderful questions. I think, Professor, you can go ahead and respond to the questions. Professor, you can go ahead and respond to the questions directed towards you.
Sorry, was that for me?
Yes, Jess, you can go ahead.
Okay, I'll go ahead and address the economics questions, but I'm going to leave the health-related questions to Wincy. So first, actually, there is a great question about how we cost for the space that was used, and the more general question of would we expect these costs to come down over time. And this is something that I should have mentioned in the presentation, is we should always be thinking about the costs that I'm presenting here as these are the worst case scenario costs, because we're still figuring out how to do things. So we're probably going to be doing things less efficiently than they could be done. So I would expect over time, we would get much better at delivering and much more cost effective at delivering these programs. For example, if doing pulmonary rehabilitation becomes very commonplace treatment, then I would expect to see a lot more patients per day going through the programs. And that just means that you're using all of the inputs into the program in a much more efficient manner. So the simple answer is, yes, I would expect that we would get much better at, or much more cost effective at delivering these programs. So the 6,000 I reported, this can be thought of as a worst case scenario number. Also, in terms of the cost of space, this is one of the big advantages if we have hospitals and other medical facilities that have unused space, is that space can be put towards using for something like a rehabilitation program very inexpensively, and we should be taking advantage of that, definitely. The other question was in terms of the threshold, the NICE threshold being used. And this is a really good point, and this is one of the reasons why we wanted to introduce these other productivity and work-related measures, because it may some people may think it doesn't make sense to look at something like a nice threshold, which was really developed for countries like the UK and the US as being the threshold we use. Now, I just quickly looked up the per capita GDP for Uganda, and it's about $1,200 in the last year per person. So compared to the 6,000 that we reported for the program, so that would, I mean, I'm not sure how to interpret that simply because, I mean, one life year, the program, what we're essentially saying is that the program buys one more high quality life year for every 6,000 US dollars spent. And, you know, a high quality life year is worth much more to a person than just their income. So, so it's a little bit difficult to think about how to interpret that in terms of cost effectiveness, but that's something we might want to think a little bit more about moving forward here. Also, what was mentioned is the societal costs of the work improvement benefit. So I mentioned that, you know, for the average teacher, an extra 5 hours per week translates to about 90,000 shillings per month. This, of course, is just the benefit to that one individual teacher. Now, if we think about putting everybody with chronic lung problems through one of these programs, and they each experience an average, at least on average, they experience that sort of an increase. Well, this is going to start to have real societal impacts. So it's not just that one teacher, it's that you're putting all teachers within Uganda who go through this program, they work 5 hours more per week. And now you're talking about a real societal effect on GDP, because that translates into more students being taught and so on and so on. So you're going to have spillovers into the larger society. Now, this is a very difficult thing to start to quantify, but I think it would be a good use of time to try and put some numbers around that. Absolutely. So I'm going to leave the questions there unless there was something that I missed. Please let me know.
Thank you for the responses, Professor.
I don't know if you have any other questions for Jesse, because he may want to go to other things. He's in the UK, so we'll prioritize his questions. And then we have another presenter from the UK who will answer a good number of the questions that have been emerging from the talk, and then we will address the remaining. I've written all of them. None will go unanswered.
How long is a PR program? When do you discharge the patient out, and would it be of benefit maybe later on to consider modeling lifetime benefits of PR?
Wow, I think that speaks very much into, and okay, so the first phase has the hospital-based intervention, which is 6 weeks. So that is the standard hospital-based rehabilitation that we have been offering in Uganda. Of course, when you read in literature, some people may want to give it 3 times a day, or even some slightly longer duration of about 8 weeks. But according to standard guidance, there is a range of everything that you can actually give. So our program is twice a week for 6 weeks. Then after that, they have another 6 weeks of training them how to do the same exercises, but do them at home. So because eventually pulmonary rehabilitation should be a lifelong treatment. So it's not a malaria kind of treatment that once you've taken your medicines for 3 days, you're good for, you're good. So, and that's what the conversations were about yesterday. So some of the patients we saw had participated about 3 years ago. And now they started telling us that, in the first year I was running, I was doing all these things, but I stopped exercising and I'm starting to experience breathlessness again. So meaning that the body was starting to forget all the training that it had acquired. So it's really something that has to be a lifestyle change where you embed exercise into your daily routine. So I think that probably will show that. So there is really no end of what this rehab is. So even in other programs, patients can always come back after some time and they say, oh, now I've come back to do the rehabilitation again. And then we take them through all those things. Even yesterday we had some mini education session because some of the participants had forgotten some of the information we had given them and some of the things to expect, and we had to re-echo them. Yeah, so
sorry, if I could just add on to that.
Yeah.
I mean, one of the other things that this highlights is the fact that the cost-benefit estimates that we're proposing, these are really lower bound estimates because they're only capturing the effect of a 6-week program. You could imagine if even half of the patients who go through the program have a complete change in lifestyle because of this program. This will have a lifetime benefit in terms of their productivity and their ability to look after themselves. And again, this is something that is definitely worth thinking about. How do we quantify those benefits? Because that's where the real change is going to be coming in.
Okay, so we probably will take a few more. We'll have a very extensive Q&A session, including those that are coming in from online. We just want to right now give priority to some of the presenters who are presenting from outside countries because they may want to start the activities of the day. Then after that, we'll really dive in and answer and discuss and see if there are other things that will emerge. That's why we are here.
Okay. I'm just curious. I don't want to forget the context in which you measured the quality of life, especially outside the hospital care. What is it on individual basis in the activity within their homes, or do you have any experience in measuring quality of life in a collective environment, like with among TB survivors? We have some groups around where maybe you incorporate things like football, other joint activities. If the context is the same as within an individualized activity-based kind of rehabilitation or a group context, that is, I didn't want to forget that. You can answer it or put in the parking lot. Thank you.
Yeah, that's a really interesting question. So the simple answer is, so we're rather agnostic about the context in which the quality of life assessment is done. So when we deliver this questionnaire, we don't really know what the situation of the individual is. So it might be somebody who has a lot of support, and therefore their quality of life response is going to be very different. Which is why it's important that we're comparing the changes over time rather than just looking at baseline support, because or quality of life in the 6-week period, because everybody's different, and it could be that the treatment group is systematically different than the control group. But I think this is, it's getting at something that is important. So one of the challenges we have with collecting data is we have to collect the data in a way that is cost efficient for the program and is reasonably easy to deliver, because there is a lot of data being collected. So we tend to use these questionnaires like the 5-dimensional European survey, because they're ready to use, they're validated, and they're very easy to deliver. It's just 5 questions that an individual can answer. But it's probably worth thinking a little more about the context as you're asking. So then we could start to get at questions like, do these programs work, or are they more effective in people who have very strong social support systems, for example? Yeah, these are all questions that are worth thinking about as we move forward with programs like these.
All right. Thank you so much, Jace, for the presentation. And I think the questions that have wonderfully been answered. These conversations will continue. And I know we've had some of these when we're doing the calculations for the qualities, you know, our experience where we have, you know, free spaces, hospital, and then even the some of the existing things where you don't have actually to invest a lot of money to actually start the program. So I think these conversations will continue even after you have logged off. So yeah, so next is Buyem Dashiru. He's going to present. I hope he can hear us. Yeah, yeah. Yes, so he is loading his slides. So he's going to take us through some of the results that we have from trying to roll out pulmonary rehabilitation in primary care settings. And these, again, will bring interesting discussions in terms of rollout and scalability. Some of these questions have been emerging from this discussion. So it's after that that, again, we will have other conversations. We also have one of the participants who was here yesterday. She'll also take us through. We thought we would conduct as many, but some of them were quite engaged. But she will take us through. We had very wonderful testimonies yesterday. You would think these were close to miracles, but we will hear the lived experiences for the participants themselves, what it means to participate in pulmonary rehabilitation and all the benefits. Buya, I see you online, so over to you. Please briefly tell us where you were.
Yes, good morning, everyone. I don't know, it could be an afternoon on your end. Abuye Mudashula, and I'm a research fellow at Makerere University Lung Institute. Also a PhD student at Makerere University. And where I am, I happen to have won the 2024 African Visiting PhD Fellowship at the University of Warwick. So I'm here for a couple of months as part of the knowledge exchange between the university and the African institutions. So I'll share on behalf of the team that worked on this project funded by Global Fund on the what it means implementing post-TB lung disease care and rehabilitation in Uganda. And this implementation is within the public health facilities, not like a clinical trial, like the research project. So I won't bore you with the statistics, you all know them, and where we are with the TB treatment success rate. So this project, we aimed at establishing the level of low-cost pulmonary post-TB lung disease care to TB survivors, attending diagnostic and treatment units in Uganda to assess the feasibility, the effectiveness, as well as the scalability. Specifically, we One, we aim to conduct a baseline assessment to determine the burden of PTLD in selected health facilities, representing the different levels of health facilities in the country. Also conducted a service availability and readiness assessment for provision of PTLD service care in Uganda health facilities. Also build capacity amongst healthcare workers. Establish, implement a low-cost post-TB lung disease care package at these selected health facilities. And lastly, to support setting up a PTLD monitoring and evaluation system or database to enable programmatic evaluation and impact. So this project deliverables included we had to support the National TB and Process Program to draft the National PTLD Response Strategy and Action Plan, drafting national training manuals, SOPs, and job aids on PTLD care, and also provide a brief on the service availability and readiness of our health facilities to provide PTLD care, and enhance capacity of the primary health care workers to deliver PTLD care, primary rehabilitation, but also reach as many as 500 post-TB patients and assessed for PTLD, but also among those that have PTLD, enroll primary rehabilitation amongst them, and also draft a national scale-up plan for delivery of PTLD care. What I can say is, as per these deliverables, as a project funded by Global Fund, with sponsorship from NTLP, MLI managed to achieve these deliverables or outcomes. So these are the facilities we selected. 2 regional referral hospitals, that is Jinja and Naguru. 1 general hospital in Chiboga General Hospital, representing the rural areas. 2 health center fours, Kasangati and Wakiso Health Center 4, and also 1 health center 3, which is Chitevi. As you see, we managed to try and see that we get at both ends of the health levels in our healthcare system. So as per the needs assessment, we found out that none of the facilities was providing post-TB lung disease services at the time. And it's only 1 facility that had at least a clinician or nurse trained in post-TB lung disease care. And this facility is Naguru. And the reason is they were implementing a study by Dr. Rodria on post-TB lung disease care, but also another study by colleagues at NTLP. Dr. Treyonje is there with you. So that is the only reason why they had that nurse. So all the facilities had the best equipment to support clinical service assessment of post-TB lung disease. And these facilities are available at the TB treatment units, utilized for other, for similarly same services for TB care, TB diagnostic and care. Of the 7 facilities assessed, only 3 had a physiotherapy department or unit with trained physiotherapists. As we know, that regional referral hospitals and district hospital at least have a physiotherapist deployed there, and their units. So, and those same 3 had radiologists available, but none had a pulmonary technician deployed. I don't know whether Dr. Katajila was able to define who a pulmonary technician is. They are not the same physiotherapists. I'm sorry to give an example of Mr. Kasita is a physiotherapist. Pulmonary technician is another person. One of the facilities had a physiotherapist trained in chest physiotherapy, and that is Naguru, the same facility that was undertaking a study on PTLD care. All of the facilities had enough space to roll out post-TB lung disease care, and also all of the facilities had space to conduct a 6-minute walk test. This is what we used as our measure instead of there is that test which you talk about, which Winters asked, the shuttle walking test. Also, they had the chairs that we could utilize, but they did not have, none of the facilities had other rehabilitation equipment that we could utilize. So in this study, we developed a package, PTLD care and rehabilitation package, and we benchmarked on the research project. And the package includes, as the first step, to screen and test TB patients for TB using the National TB Diagnostic Algorithm. And here we are looking for anyone that has recurrent TB or has active TB. The definition of recurrent TB is something we need to discuss more. I know Dr. Luz is there with you. We've been having this discussion more. And we found out that majority of our post-TB patients may have recurrent TB. So in here, if you were positive anyway, could not enroll you into this prospective work, could link you to TB care, and you link it to TB care. So any negative on TB, any negative TB patient amongst this pool of post-TB patients would go ahead and conduct a syndromic diagnosis. Syndromic diagnosis included assessing for chronic respiratory disease, doing quality of life assessments using the MRC, the CCQ, and the PHQ-9, and also we could manage at these different facilities. We could refer or manage, like for health center 3, health center 4, we could refer you, but for regional referral hospitals, we could manage these specific PTLD syndromes that you have. So then after, we could also conduct a disability assessment. And here we are looking for eligibility for pulmonary rehabilitation. The disability assessment was conducted, as you will see in the next step, using mainly the 6-minute walk test and also the MRC score. So, but if you are not eligible for pulmonary rehabilitation, we could refer you for further evaluation. Then we could treat this disability with what we term as low-cost pulmonary rehabilitation. And this included patient education and exercise training. I know Dr. Katajira has elaborated this in his work because that is our benchmark, project. So in addition, we developed some program, some indicators, and these we monitored as part of the M&E and for purposes of improvement in quality of life of these patients. So these are the tools we use to identify post-TB patients. We worked with the health facilities at the health workers at the facilities to identify TB patients through review of the TB registers, get a pool of those who have completed TB treatment, successfully completed, and then you reach out to them and see how are they doing. Also, we're doing TB patients discharge points. As you are being discharged prospectively, we're encouraging healthcare workers to assess immediately for post-TB lung disease amongst these patients. Also, at the outpatient, the inpatient department, there is a comment, I don't know, from either Irene, that talked about people come to these facilities with these problems, and this could be at outpatient or inpatient. So these are walk-ins that we could also, at these points, we could also identify post-TB patients. Also through phone calls to previous TB patients. So as part of the contact tracing or the tracing of these patients, the review of the TB registers, we could encourage healthcare workers as they are doing their contact tracing, and they could reach out to these patients that completed TB treatment and see how they are doing. But also through community awareness using the existing community health care system. So once we identified you as a post-TB patient, this is the assessment flow chart that we developed as one of the job aids we have at the different facilities. We could do as said before, we screen for TB such that we can rule out recurrent TB. And these samples were referred for culture at NTRL. Then after, if you're eligible, we could do chronic respiratory disease syndromic screening for cough, and other things, CCQ, PHQ, and also the 6-minute walk test. Then after, we could, if she had any chest pain or hypertension or wheezing, we could first work with the health workers at the site to stabilize you. Then do the MRC Dissemination scale, and we could only enroll based on this MRC score and into the low-cost pulmonary rehabilitation. And we conducted review at every PR visit and discharged at 6 weeks of PR activities. In the subsequent slides, you will see the implementation of these low-cost within the public health care system and what it could achieve with the preliminary results we are sharing with you today. So the summary descriptive results is that we reached out to 510 post-TB patients, and 136 of these had PTLD-related symptoms based on this CRD, the quality of life, and the CCQ-PHQ-9 assessment. We started 83 over 136 on pulmonary rehabilitation, and these about 61 that started pulmonary rehabilitation, and about 7 of those actually completed pulmonary rehabilitation, and this implementation entirely we utilize healthcare workers at the facility. We did not add on anyone. We provided remote support supervision and also weekly, drop-ins to healthcare workers to troubleshoot here and there. But all this was done by the healthcare workers at the different facilities. I'll bring out this bar graph in this slide. So for Ginger, it screened over 83 post-TB patients, and 43 of these had PTLD symptoms. 17 started PR and 9 completed. Kasangati screened 98 with 14 with symptoms, 11 started pulmonary rehabilitation, and 10 completed PR. In the next slide, I'll show you how the results of Kasangati specifically. And Chiboga did 40 screenings, 29 post-TB lung disease, 18 started treatment, and 7 completed. Chitevi was one of the surprise packages, and the Global Fund team were interested in Chitevi as a health center 3, but screened over 80, and 21 of them with symptoms, 20 started pulmonary rehabilitation, and all of them completed treatment. That is the uniqueness of Chitevi as a health center 3. And this shows that, it is very feasible to implement the same thing in the lowest facility we have in our country. Now, Gulu screened as many as 118, 5 with symptoms, 3 started PR, and 3 completed. Wakiso 91, 24 symptoms, 14 started PR, and 9. So the cascade is as that. That's the cascade we want to show as part of the PTLD implementation, monitoring, and evaluation cascade that we developed. So just to show you the implementation of PTLD patients across the PR visits, I know Wins may have provided this, the different exercises, the biceps curl, the sit to stand, the pull-ups, sit-ups, resistance. As you see, the implementation of these showed some good results. And descriptive wise, yes. But as you see, there is improvement, even the mean repetitions of bicep curl amongst our patients from 25 at visit 0 at the enrollment baseline to 81. The same from sit to stand from 14 to 83. The pull-ups from 13 mean number of repetitions to 83. And this is the same as step-ups and resistance. So this shows some good, the feasibility of this within our facilities. But also this is interesting. As you see, I said I'll pull up Kasangati. The improvement in the 6-minute walk test among PTLD patients following PR. And these are patients, 11 of them started, 10 completed. Their mean age is 36.7 years and range of 21 to 58. So the range is as broad as that. But as you see, patient 1 started with a 6-minute walk test about, below 400. They completed with about 500. Patient 2, there is at least some improvement in each patient. There is patient 10 who started, who was assessed at baseline but did not complete, and their result as patient 10 is there. So also this shows that, it is feasible to implement the same. We had total 11 patients starting PR, 3 of them being female, and the others, they were male. But definitely, we all know TB affects male most. So the preliminary analysis of about 368 patients, and this is data we are cleaning, as you know, implementing some of this work in the public health care setting, you have to do a lot of cleaning. But so this shows that over 61% were, male with a mean age of 38 years. The baseline mean weight was 57.5 kgs. So majority of these patients that we enrolled or we screened had a biological confirmed primary TB, biological confirmed primary TB patients at their time of diagnosis. But also we have some clinical diagnosed PTB and extrapulmonary TB. So the work was done across all groups, all TB patients that we receive in our facilities. 29.7 presented with cough at an early assessment. We had some having hemoptysis, shortness of breath, fatigue, chest pain, but also their number that did not have symptoms. The mean 6-minute walk test as assessment was 441 with variation of 120 meters and a range of 30 to 1,017. So the mean COPD clinical questionnaire score, a total score of 6.8 with a variation of 8.2. That's one is a big variation. Probably Dr. Weiss will talk more about this CCQ and how it is interpreted. So the CCQ symptom score of 2.8, similarly with a 3.5 variation as SD, a CCQ mental score of 0.9, similarly with 1.8 variation, and the CCQ functional score of 2.9, similarly with a large variation of 4.7. So large variance of variation of 4.7. You're looking at the PHQ-9, 27.3% of these patients had minimal depression, and 6.3 had mild depression. Moderate depression about 1%, and about majority do not have depression. But what we have to see is that there is an aspect of depression within our facilities. And as you know, as I said, these assessments were done by our healthcare workers. So there could be, this depression could be more probably assessed by a trained medical, probably mental health person also. So the MRC score, the short of breath when hurrying on the level walking up a limit was about 10.3% of these patients reported they get shortness of breath when hurrying. About 7.4 say they walk slower than most people on level. About 4.1 say they stop for breath after walking about 100 yards after. And these are all TB, post-TB patients. But over 78 say they're not troubled by anything as regards to breathlessness. I would want to present you a case study of this patient. I know a good number of you may have seen this, but it's my signature case study. But we have as many others that we have similar reports, case studies about. This was a patient, 50 years old, a female, coming from a rural setting, bacteriologically confirmed by TB. Time of diagnosis came with cough, chest pain, tiredness, and having a 6-minute walk test of 310 meters. So when you look at the repetitions from 8th February 2024 to 14th March 2024, along with their visits at the facilities, they went on increasing the weight they were, taking, but also the repetitions were improving. I know Casita may have a better story about this, but this is another way of showing improvement, and this is work that was done at Jinja Regional Referral Hospital by the physiotherapists at the unit at Jinja. So showing that there is improvement in this patient. So the reporting and recording and reporting tools we developed to support this work was we developed a presumptive PTLD register, we developed a clinical assessment tool, we developed a patient flow chart or job aid. I had a slide on that. We developed a PTLD M&E framework. We developed a pulmonary rehabilitation SOP, a 6-minute walk test SOP, and also a recurrent TB sample referral standard operating procedure. And all of these are with the team at NTLP have access to these. So the lessons learned in this feasibility study or pilot study that we did is that the burden of post-TB chronic respiratory syndrome is high among Ugandan post-TB patients. As you saw, over 27% of post-TB patients had a CRDO, reduced quality of life. All our facilities assessed did not have PTLD care services. And there is need to build the capacity of public health facilities to provide PTLD services. As you see, when you provide the capacity, they are able to do it. Also, there is need for continuous on-site mentorships and support supervisions of the healthcare workers because it is a new thing to them. We realize the PTLD care package is feasible, acceptable, and scalable within the routine care setting. The results have shown probably could help convince you of that. So also, we noted that there is some limited adherence to the PTLD program due to financial and time constraints. Patients, we did not have any financial support to patients. We did not pay participant reimbursement. We did not pay anything. So as you try to follow up these patients to come for a visit, to come for a PR assessment, they was to give reasons. Coming, they have to come for 6 visits. That means if someone is spending money for all of these 2 times a week visits, it is some some work for them, and it gets onto their out of pocket expenditures. So we need to understand the catastrophic costs. However much that the results from the research have shown that there is the financial benefits are there, but the catastrophic costs of these post-TB patients to continue coming for this PR needs to be looked into. So just to give you a snapshot of what we did here, patient at Kasangati, but also this 6-minute walk track at Naguru that our team at Naguru during our implementation designed, showing how health facilities can improvise within their space to design this program. Also, this work can be done at the back of health facility. And as you see on this end, one of the patients is doing some pull-ups, and another is doing sit to stand, but also on this other end, another patient is doing PR. So I would want to acknowledge the NTLP team, starting Dr. Stavia, Dr. Ruze, Dr. Bialhanga, Dr. Emmanuel, and also Jeff and the team there, and also the MNI team that was led by Professor Bruce Chilenga to undertake this work, and also funding from Global Fund, the PTLD operation team, and also we benchmarked on the discharge project to get an understanding of how to implement this work. Over. Thank you.
Thank you, Buye, for that wonderful presentation. If you look at our time, we are already within lunch time, and we are discussing here, and we suggested that possibly Wincy and Professor Sally may respond to the questions that were raised before, and then we push what would be the next presentation after lunch. So now I call Wincy to respond to some of the questions raised before.
Right. I don't know how much time we can use before lunch. The questions are quite many, but at least from Buye's presentation, a number of them we answered. There was a question on scalability, a question on capacity building, a question on how to design rehab programs lower down to the communities where people can access them. And I think you've been seeing that in the park project, the project that Buye has just been presenting. We actually used lower level centers. Chitebi is, I think, Health Center 2 or 3. It's a very, it's a very community hospital. Don't take a hospital. Okay, maybe hospital, because yeah, it's really a Health Center 3, I think, to be specific. So we really used, or we deployed very much community settings. And you can actually see most of the questions that came around age, around adherence, around, you really see that there was a lot of similarity, even in the routine care settings. So I don't know if I can, let me see if we can project some few slides to just clarify some of the points. Just give me a minute. The good news we are receiving is that lunch is not yet ready. Yeah, so we can actually use more time to have conversations. So I'm just trying to go to the questions. So just waiting for so let's go to, there was a question on yeah, so there was a question, I think it was from Dr. Luze, who was noting that most of the participants were a bit younger, 43 years, and there was a question on whether age might have impacted response to exercise. If you saw, for example, the case study that Buye showed, that participant was 50 years, and you also saw the dramatic improvement with exercise training. There have been conversations around younger people having better physiological, states and metabolic states, and therefore they might respond faster. but most of the literature shows that age is not really a critical factor in terms of response. And that's actually why you see younger children. We have rehabilitated younger children in the routine care settings, and they've responded as well. So although, of course, we don't have enough data to really show or even guide on how they will respond, but we just have routine data that children as well have benefited immensely from the pulmonary rehabilitation. And then there was a question, so I think it was Dr. Aldo who also noticed that we showed that only 30% of our participants had normal spirometry, and you wondered what would have happened if we would have repeated the spirometry at the end of the rehabilitation program. There's actually a lot of data that shows that there isn't that much of a difference in FEV1 changes. Like those parameters, they actually don't change as dramatic. Pulmonary rehabilitation mostly really is around building the endurance levels and the fitness in the muscles, which will then mean that the individuals who have post-TB lung disease with the same oxygen that they breathe in will be able to actually do a lot more when their muscles are fitter compared to sedentary muscles. Yeah, so at the end of the day, of course, we'll give Prof. Sally a chance to comment on everything I'm saying. She is the expert. This might as well be my PhD defense. So, yeah. So, one of the things I wanted to show. So this is the primary efficacy outcome data that actually shows dramatic improvement in the PR arm. One of the things I forgot to mention here is you see in the usual care arm, so the baseline incremental shuttlecock test was about 408, and in the intervention was about 376. You need to know that for most of us in this room who are physically fit, our baseline incremental shuttlecock test will be around 800. So just to show you the kind of disability that we are talking about here. So when you see such movement towards improvement, it's quite significant. So and that also speaks to the person who was asking about what is like the cutoff. Which patient would you look at and say, maybe not this one, maybe we skip this one for rehabilitation. So if you followed the algorithm in the study that Buye was presenting, we actually used our experience over the last 10 years or so to design that. And what you see here is something I presented as part of background, are these clinical syndromes. So for every patient who goes into rehab, before they go to rehabilitation, we need to make sure that they are clinically stable. So we need to screen them for whatever it is that might need treatment, treat them, they stabilize, and once now the pharmacological therapy is working, we now reverse the disability using pulmonary rehabilitation. So pulmonary rehabilitation is not a replacement for treatment, for pharmacological treatment, but it does save a patient from taking antibiotics they don't need, anti-TBs they don't need, and cough syrups they don't need, because those will not reverse the disability, but the rehabilitation will reverse the disability. So if a patient, for example, comes in and they have lower limb swelling, they will be evaluated for right-sided failure, and then will be put on treatment to stabilize them, and that is when now they can enter into rehabilitation. So, and that's where the safety would come. I think for the question that was around safety, we always made sure that the patients were clinically stable before. Because I think you know that patients who are undergoing an asthma exacerbation will be exercise limited. So now when you take out that noise and the patient's now a bit stable, so whatever disability you remain with is now what will be probably secondary to the post-TB lung disease disability, associated disabilities. So, and that's when you see that on top of the inhalers they're using, exercise will tremendously improve. And there's again a lot of data to show that for patients who need inhalers, just using inhalers will improve some bit of their exercise endurance and everything else. So the pulmonary rehabilitation was over and above every other clinical syndrome that a patient might have had. Yeah. So when it comes to cutoff, the discussion was always in terms of clinically unstable in terms of comorbidities. But once they were stabilized with their comorbidities, then they would be enrolled into the trial. Okay, so then I think then there was a question on how we differentiated between. Okay, so we said that the participants had to have had chest X-rays consistent with post-TB lung damage, and there was a question on how we differentiated between post-TB lung damage from active TB. So all participants underwent GenExpert, and all those who were GenExpert positive were excluded from the study. Of course, there were other conversations with someone in the microbiology lab asking, is this live bacilli, is it dead bacilli? But actually some of them had symptoms, because you realize that in the syndromes, here you have, let me show you, the infections here, recurrent infections, you'll have fevers, and actually some were screened for that. Are we dealing with a bacterial infection or active TB? And indeed we picked some who had active TB, and we referred them for treatment and program. Okay, so that's actually how we differentiate. Otherwise, you will not know if the nodules you're seeing are calcific nodules or actually from active TB. So that's why we had to do GenExpert for all of them. Okay, it seems I'm sweeping most of the questions in tremendous fashion. There was a question on accessibility of PR and how they can be taken closer to the community. I think we have shown in the PARC project, which was a feasibility project, that it is actually feasible to extend PR services to the community, and the patients or the individuals with post-TB lung disease still benefited from the community, the PR programs near their community health facilities. There was a question on adherence, that our adherence actually was very high compared to other research programs that have a cohort kind of follow-up. Pulmonary rehabilitation has been shown to be different from anything else because of the human component that we see with the treatment. If you saw yesterday the participants who were here, it was just like we kept on taking pictures. They were catching up because it's a group kind of intervention. So you actually find meaningful friendships. There was someone actually who was testifying here that she was just following up on one of the people who were in the group, then realized that for some good time, the phone number was off. So she actually decided to walk to their home. And that's actually when they discovered that that particular participant had developed, I think, some liver disease at some point and eventually passed away. These are things that you cannot find in any other cohort program. But the people meet 12 times in 6 weeks. And the first 1 week, it is really just catching up, how are things, and encouraging each other. And they create meaningful friendships. And that's one of the things that people, so they actually look forward to attending the program because they are going to find, people with similar issues, and they're going to encourage each other. That's the thing that is really quite different. So you find that actually someone is looking forward to going for the rehab class, because of all the other benefits they're actually going to benefit from. Okay, so surely, if there is anything I have not responded to. Yeah, and also there was a question on, I think, other medicines we used. We talked about inhalational therapies, and the clinical syndromes really summarize that depending on what it is that we found. So for example, some people actually had aspergillomas with hemoptysis, and we had to first give them antifungals for some time, and once they stabilize, we enroll them into the program. So whatever it is that actually they have as their clinical syndrome, we first treat them and stabilize them, and then they can benefit from the exercises. All right. Okay, it looks like yes, someone was asking why incremental shuttle walk test and non-6-minute walk test. The incremental shuttle walk test, so we have been privileged as the Lung Institute to collaborate with innovators, people who have what we would call intellectual property. I think you remember Professor Tis Van der Molen. He's the brain behind CCQ. And in this room, we have the brains behind the ISWT, Professor Sally Singh. And what you actually find is that the incremental shuttle test is objective, is an objective measure of your exercise capacity, free of corruption, free of cheating. When you have seen, or if you have ever observed someone who is doing a 6-minute walk test, they will walk as they feel, according to their mood, according to how they feel. So there is really no objectivity. So for example, reproducibility will be an issue. So someone will walk a different distance today, and if they come 3 days later in a very good jovial mood, probably they received some good mobile money, you will say that they will walk with a spring in their step. So then that lack of objectivity is what makes the 6-minute walk test a bit different. The beauty with it is that it's quite popular. But also when you look at the SOP, how it's supposed to be implemented, ideally they should be on what you call endurance in kind of paced, walking. But some people just really move any way they want. So sometimes the objectivity probably is not there. The ISWT is highly reproducible. And one of the things actually that we did, participants did 2 tests on that day. And we took the one which was better. And it's really, again, to show you the rigor of measurement. But who am I to talk so much about ISWT when the Professor Sally is here? So we can hear a little bit about...
Exactly. So it's always an interesting debate which test you should use. I think there are... so the 6-minute walking test is a self-paced test. So if I said to all of you, you've got to walk as far as you can in 6 minutes, it's quite challenging to know how to do that. So the problem is patients don't know what to do a lot of the time to get a maximal performance. And the 6-minute walking test is an externally paced test, so patients don't have to decide what pace they walk. It's sort of dictated for them by bleeps that are played from an MP3 file. So in the context of rehabilitation, that's particularly useful because you identify somebody's maximal exercise capacity. And if you can identify somebody's maximal exercise capacity, you can then prescribe an exercise program for them. Whereas if you've done a 6-minute walking test and it's self-paced, they probably haven't pushed themselves as much as they could. So I think that in rehabilitation, it's a more accurate way of prescribing. And then in each centre, you know that you do exactly the same test. So if I did a test and then Bruce did a test, we both got 400 metres as the result, the test would be exactly the same. Whereas for a 6-minute walking test, if Bruce and I did a test and we'd both done 400 metres, we wouldn't know whether we'd done it slowly or you're actually allowed to stop and rest in a 6-minute walking test. So somebody could walk really quickly for 2 minutes and then stop. So it's really difficult to compare either between centres or actually within a patient, because somebody could do 400 metres in 2 completely different ways before and after rehab. So it's not a terribly objective test. And then the other advantage is, and this I think relates to some of the conversations that I'm sure we'll probably have now or this afternoon. The 6-minute walking test will have a ceiling, so you will limit your ability to detect change. And if you think all of these people that are coming are younger, and one of the discussions is should young adults and children come for rehabilitation, then you need a test that's appropriate for everybody. And it's likely that a 6-minute, children will won't blink an eye and they'll do a 6-minute walking test, and you just won't see any benefit from your program if people max out on the test. And you won't get that with a 6-minute a shuttle test, because there's ultimately 12 levels for the test to go on. And of course it's a shorter space. You only need 10 meters to do a shuttle test, whereas you theoretically need 30 meters to do a 6-minute walking test. So if anybody ever wanted to publish any of their data, you would need to be able to establish that you'd done it on a 30-meter course, which is quite tricky, particularly in community settings. So just on a very practical basis, the shuttle is easier and it is more objective and likely to be better over a range of participants in rehab, particularly if you're looking to offer this out to younger people. Okay, I've got a list here of the questions I thought were quite interesting. One of them was around survival, and there is a data to show in a COPD population that if you improve their exercise capacity, i.e. their cardiorespiratory fitness, you improve their survival. And there's a lot of logic around that. If you make people fitter, then it's likely they will survive longer. So clearly you would need to collect data over a 5-10 year time frame, but logic would dictate that if you're improving somebody's exercise capacity, you're improving their cardiorespiratory fitness, so you will improve their survival. And clearly you don't have the data on that, and it takes a long time to accumulate that data, but logic would suggest that that's likely to happen. I think that's probably fair. Somebody was asking, I think, about the timing of the intervention, and I think one of the interesting questions is whether you could offer a rehab program during the acute phase of the TB management. I think there's a bit of interest in that now. We've been working with a team from the States who are actually working in India, and we're looking to develop the digital intervention, so that might be used during the acute phase of management. And there's some logic to that as well. If you can prevent the decline before it started, that sort of makes more sense, but that's not been tested. But there is some logic to doing that, I think. You were talking about the age of participants. In the UK, the average age of our participants is about 67. So the productivity and the return to work I think is a fascinating additional value of rehabilitation that we wouldn't see in high-income countries, because most people will have naturally retired. So I think that is really strong data to show that in a working age population, people become more productive. And we heard yesterday some amazing stories of people's lives going back to normal and taking up hobbies that were really important to them, so their quality of life was just so much better as well, and that would drive down health costs. And then the last one that I've got that is the big question is, and it's true for all of us, how do you maintain a healthy lifestyle? So if I asked all of you now, do you exercise regularly? I don't know how many of you would put your hands up. If I asked you all, how many of you know that exercise is good for you? Well, I suspect you'd all put your hands up. So patients are no different to the rest of us in the room. It's making lifestyle changes is tough and needs support. So I think the strategy around maintenance is an interesting one and is still being investigated. So I think there's excellent data from the group showing that rehabilitation works. The next challenge is maintaining that benefit, which is absolutely true for all of us. We can all, have a New Year's resolution to go to the gym, and then by February the gym's empty again because everybody's decided that's, they can't be bothered. So patients are no different, or we're no different to patients. So it is a challenge, and I suspect will be another area of research, because I think if people can get back to work, there's a real vested interest in people maintaining that lifestyle change. So it would be interesting to look at different strategies people motivated? But if anybody knows the answer, that is the million-dollar question.
I know TB is TB, but I just want to ask questions pertinent to drug-resistant TB. If you were able to recruit some of them into your studies, and how, if there was any difference noted in the improvement or the level at which they joined the program, or if we can use the same requirement, recommendation for all. Just really curious in that area.
Good afternoon, everybody. My name is Susan. I am a TB physician. I'm happy to be back. I've been away. Thank you. Thank you. So I know I missed a bit of it, but I'm interested in this particular patients who had end-stage post-TB lung disease. You know, post-stage fibrosis, it's irreversible, but they need to be rehabilitated and they need to be supported in their rehabilitation with portable oxygen. Did we have them in the cohort? In terms, now we know that it is something that we can do for our patients. How do we ensure that such patients benefit from PR? How do we ensure that there is portable oxygen to ensure that they also build their muscle strength and are able to get back at least their life? They're able to work. They may not go back to work, but they're able to do their daily living and be with their family and live a reasonable life. Thank you.
Maybe just to first address the question on MDR TB versus DSTB. Our thinking, usually when you hear MDR TB, is the thought of extensive damage and all these things, but we actually are getting a lot of index cases. First TB, MDR TB. And when you look at the lung parenchymal damage, it is actually the same. So, and then we also have patients who have been genuinely treated for TB about 3 times across maybe 20 years. And the improvement was the same. In fact, yesterday, just to respond to Dr. Adakun's question, we saw participants we had not seen in 2 to 3 years, and just looking at them made us excited, looking at where they were to where actually they are. And actually, we have one of the participants who made it today. We had invited many, but they were caught up a bit. And we will give her some bit of time to tell us actually where she came from. And so one of them actually will tell you he couldn't move from that table to that table. He couldn't. Even just getting out of bed to the chair was a problem. Now he's walking from Lagos stage to Cancer Institute without resting. So that's the kind of testimonies we're getting yesterday. And for anyone who has not seen this, they will ask, but which kind of treatment is this? But those are the kind of testimonies the patients will tell you how much exercise actually can do in rebuilding in reversing the disability associated with the post-TB lung disease. But of course, we also know that it's really not just post-TB lung disease, but also other lung diseases. We were discussing about ILD, we discussed about everything else, bronchiectasis and COPD. So anything that is going to really lead you into what we call the vicious cycle of deconditioning will actually benefit from pulmonary rehabilitation. There is a lot of, which is basically what we screen for patients when they come. When they realize they become breathless when they walk, they start to avoid walking. And unfortunately, the more you avoid walking, the more deconditioned you become. The more deconditioned you become, the more breathless you become. So that's what we actually call the vicious cycle of decline. it's basically rehabilitation that actually starts to rebuild you and reverse it back to where it's supposed to be. Yes, so yeah, and we also discussed extensively about portable oxygen. In the UK, when you go and see their rehab programs, the many times I've been at Leicester in their rehab programs, patients are moving with their portable oxygens and rehabilitating, moving up and down. It's a bit of a challenge, and we had that discussion yesterday, where the portability of the oxygen in our setting is a bit of an issue. What we call portable oxygen are the small cylinders, which actually are not as portable. What you see is people have their things in their backpacks, and they are moving around. That's really the idea behind portable oxygen, and it remains a challenge, because then that it would mean that you would extend that to people, especially, I mean, we discussed that where people really fear the desaturation during exercise. Oh my God, it drops to 40 when the patient die. But I mean, from what we were discussing yesterday, it's expected, and it's really just to encourage the patients that it will not kill you just having your oxygen sats drop a bit. But I'll hand over to Prof. Sally for any addition.
No, I think it's an interesting question, and we don't have that much TB lung disease in the UK, although interestingly it's a growing problem. So I think that we will reflect on everything that you've done here and potentially take it back to Leicester, which is always interesting. But we see a lot of people with interstitial lung disease, so, you know, fibrotic lung disease, and they are prone to desaturate, alarmingly so sometimes. But there's no evidence that oxygen makes the outcome of rehabilitation any better, which is quite interesting, because you assume that oxygen would allow people to train at a higher intensity, but the evidence doesn't show that. We see people in the UK, and I don't know if it's the same here, people get very attached because people assume that if they're breathless, that's because their oxygen levels have dropped, rather than they're unfit. So I think people confuse having oxygen with that relieving their breathlessness, and I don't think that's always the case. So I think the jury's out in terms of the benefit of oxygen in the context of rehab. If a patient is on long-term oxygen and doesn't desaturate when we exercise, we probably wouldn't use oxygen in a rehab program. Well, in fact, we wouldn't, because it's just more trouble than it's worth on a practical level. If patients desaturate when we do an exercise test, we would repeat the test with oxygen to see if that improved their saturation levels. And then if it does, and it doesn't always, we would then have a discussion whether they wanted to use oxygen or not within the context of a rehabilitation program. A lot of people say no because they don't like the hassle of carrying the oxygen cylinder, and there is no evidence that it benefits currently. So I think there's a lot of unknowns around the value of oxygen in the context of rehab. What we wouldn't do was ever exclude anybody from rehab because they were severe. In fact, quite the reverse. I think there's more to be gained by rehabilitating really severe people in terms of percentage gain. So I'd absolutely not discourage you from referring those patients in.
All right, so just before we receive any news for lunch, so we have a brief testimony, or a brief story, not testimony, a brief story of a lived experience of pulmonary rehabilitation. And the person who is going to tell us today is Sylvia Nalukwago, who was also here yesterday, and we are glad that she was able to make it again today. Okay. Over to you, Sylvia. Tell us.
Yes, hello everyone. Am I audible enough? My voice, I have a soft voice. By the names of Nalukwago Sylvia. A client at the Makerere Lung Institute. Some years back, I used to stay with my dad, who used to take cigarettes. He used to smoke it from within the house. He used to smoke from within the house. I got some kind of pneumonia, those coughs, as you know, the flu. Later on, he passed away. So in 2017, I saw there is one doctor called Dr. Mutamba? And there were some posts in Mulago showing that there is free asthma tests in Chirudu. So when I called on that number that was on that post, they told me to go to Chirudu Hospital. When I went there, they tested me and they found that I had a COPD. And again, they had to send me to Mulago Lung Institute. I did not know that it is even there in Uganda. I had never been there. So on reaching there, I met Musao Grace Chintu, who handed me over to Musao Jalia, Dr. Jalia. They worked on me, they did the spirometries. The doctor counseled me about the COPD. Actually, I thought I was going to die when I learned about that lung disease that I had. I thought I was going to die. I always saw myself at the verge of death, and I was like, how am I going to leave my 2 children? Will I die in sleep? And my kids wake up when mommy is already dead? But I had a lot of questions, and I'm so happy that our doctors are patient with us. Whichever question you come up with, whichever question you ask them, they reply positively and they tell you the truth. So I used to ask her, Musao, will I die? I mean, am I going to live up to old age? And she told me, okay, I also asked her, does this disease have a cure? And I needed an answer. So she told me the truth is that it does not have a cure, but it can be managed. And you can live with it for as many years until old age, so long as you're on treatment. So they gave me inhalers along the way as I was on treatment. Here comes in the recharge study. I had suffered from TB some years back when I was still young. It was my dad who used to take me, but I had not told these doctors because it was a period of COVID. We only did the COVID test. So Musao asked me, and they did the x-ray. And I told her, yes, I was at one time given those TB tablets back in Kamocha Christian Caring Community, where I used to take my ARVs from. So they did the x-ray, the results came out. I was enrolled and participated in the recharge study. The first day, it wasn't easy for me. Everything was like difficult. I remember Dr. Kasita. He used to encourage us. Situla, there are those things that we used to carry. You sit, you get up, you sit. And I was like, oh, I'm just 38 kilograms. And now look, Musao is not even sympathetic. You know, you climb the steps, you come down. You go on. But later on, the second week, I experienced a lot of change. I had that thing of, how do you call it? Is it the mucus? I started coughing, and it came out just because of the exercise. I have a talent of singing, and I had recorded my 2 songs some years back. But when this disease grew in me, when it progressed to the level where it was, I lost hope. I thought I would never sing again. I started training my daughter to be the superstar in singing now. Miracle trended on TikTok, and I could always sometimes even sit in the house and I cry, and I was like, oh my God, I will never sing again. But I'm so grateful that after the recharge study, I went back to church. I joined the choir again. And the pianist was like, Sylvia, all along you knew how to sing, but you are always sitting in the congregation. How comes you're seated on your gift of singing? That is a gift. I was so happy. that I could move together with the pianist, the guitarists, the drummers. And today, I'm the best singer in the True Vine Choir at the Fresh Fire Deliverance Ministries in Nabulagala. I joined the choir last year, but I was fearing. I was always in the dancers. I also feared to dance, thinking that when I dance, maybe the heart can burst, maybe I can collapse. But I'm so happy that I can dance. I was even put on the front line. The amateurs are supposed to be behind. I'm always on the front line. Yes, so I'm so grateful to you, our funders, our doctors. Thank you so much. You have made a singer at the Lung Institute. Now you've started manufacturing singers over. Thank you for restoring back the hope in me. I assure you, exercise is the best. It is better than medicine. Because I've experienced this, I've gone through this. There is someone who talked about the length, okay, how long the person can hold their breath. I couldn't sing those longer tones, the deep octaves, and I was like, okay, like I can sing as I am. I couldn't sing like, your mercy flows like a river wide. I couldn't do that because I could just, your mercy flows, and I could breathe like 3 times in a line. But today I'm singing because of you, because of the recharge study. And I'm so grateful. And I please request that Ibanange exercise muzireke wo. Yes, yes, let these exercises, the trainings continue. Yes, and also psychologically, I was healed. Someone talked about the psychological part. I was healed because I already saw myself about to die. But today I'm planning to construct a house. Today I'm saving to build my own house. Today I'm seeing my children grow. I turned 31 last month. Last month, it is this month. It is my birth month on Independence Day. So I'm so grateful that you restored the hope in me, the joy in me. I now see myself, yes, I move with my head raised high. Sichatia kufa. Last month, in the rainy season, I got cough. And one day I had a sputum, and it had blood. I ran to the Uganda Cares clinic and they tested for TB. They told me it is not there, it is maybe just a pneumonia. So I'm so happy that I'm here standing because of you. Dr. Jalia Wanzijanjaba, the one statement that she made to me, it has helped me live for all these years. She told me, you will not die, but you will live, provided you're on treatment and the disease will not progress to another level. So she told me the truth and I learned to cope with the disease. Today, I'm one person who is encouraging my friends, those that I met here yesterday. We interacted and we encouraged each other, and I was like you. I couldn't breathe. There is one time when I couldn't even walk in town. I could overuse borders, those motorcycles. But today I can walk from Chisenyi up there, Wilson Road. I can walk. I feel my lungs got a voice. I just stand and I'm like, the jam is too much. I have to go to Lusas. I'm in town. I inquire from my lungs. I just take a breath and I'm like, my lungs tell me, Sylvia, you can. Walk from here via Bakuli, Namirembe Cathedral, Sibambi Road, then you at Lusaze, because we talk. My lungs became my friends. We now talk, and if they are like, Sylvia, the weather is not good, I'm not okay, I will not walk. So thank you so much. I want to sing for you a short song. Yes, is it okay? Okay. I'll sing an English song. Yes. Your mercy flows like a river wide. Healing comes from your hands. Suffering children are safe in your arms. There is none like you. Oh, there is none like you. No one else can touch my heart like you do. I could search for all eternity, Lord, and find there is none like you. Oh, there is none like you. Oh, no one else can touch my heart like you do. Yeah, I could search for all eternity, Lord, and find there is none like you. Thank you.
Ladies and gentlemen, that was the serenade that invites us for lunch. And I think that is an outcome that a p-value cannot answer. So we had many of those outcomes yesterday, and it was just a lovely session. Just hearing all the positive stories. As I said, we know people, we remember them, people who couldn't walk, and you see them, they're put on weight 3 years later. It's just it's amazing. So I think you have your coupons now. Let's go for lunch. And then return after how many minutes?
Can we manage in 30 minutes? Because we have 3 minutes past 2. We aim to be here within 40 minutes, I think, latest. Thank you. We are informed lunch stops at 3, so let us utilize this time and we get back there as quick as we can. let us get seated and we start our afternoon session that we can leave as early as we can. We have around 5 presentations to make. And the following presentation may not be some of the information and the questions you asked could have been addressed, but we just need to see issues of human resource were raised to implement PR program, and we are just going to see how capacity building of PR in Uganda can be developed. These are ideas. What opportunities do we have? But also there are challenges that we need to sorry. So we are going to first look at how capacity building can be developed in Uganda. We shall look at possible opportunities that we have or are current, and what challenges that expanding PR in Uganda can interface with. So, to increase uptake of pulmonary hub in Uganda, we need to do the following. We need to have skills assessment of the people that we deliver PR. We have training programs. We understand that in the study which Mr. Buye did, there was an element of training healthcare workers. We need resource provision, but remember that we need to do a low-cost PR program that is not very much need of many resources, but there are those which are key. We have, and we need to find out what are the commitment towards sustainability. Shouldn't start it and stops along the way. In skill development, skills assessment, we need to equip healthcare workers with the PR skills, pulmonary hub skills. And here we need first identify the training gaps and needs. As earlier said, that most of the people may know chest physio, but the pulmonary hub involves proper education for people who are higher on the program and know the benefits, as well as the exercise programs and exercise and how they should be prescribed. We need a tailored formal training in PR. We need to have the ability to diagnose and manage positive lung disease. You realize that most of the health facilities, they are physicians or healthcare providers that may have some basic skills, but they need more knowledge on how they can diagnose positive lung disease, and they don't call it recurrent TB. To have the ability to offer PR for PTLD and other lung conditions. Much as you are looking at positive lung disease, does not exclude that there are people who are suffering other lung diseases, of which PR can be a solution if those patients are identified. Also, it's important to differentiate PR from chest physiotherapy. Most physiotherapists, they are aware about chest physiotherapy, chest drainage, postural drainage, deep breathing exercises. Knows much that exercise can do wonders to improve exercise capacity. So we need to empower them, and also healthcare workers. So the training programs for healthcare workers, what do we need to have? We deliver a structured PR training sessions through hands-on sessions and for practical skills transfer. Who are being focused as trainers, we went for skills transfer at Lister, at Professor Sally's place. And as we know, yes, we can't just talk about it without doing, and then you can understand it. And this can be done in form of workshops or form of trainings. Also, we need to increase awareness through CMEs about PR for healthcare workers in various hospitals. This involves administration, involves clinicians, and at the same time, the healthcare workers in general. As we build the capacity, we need resource provision. The needs assessment for facilities was talked about in the previous discussion by Buye, but most of the health facilities have space. But also we shall need basic equipment and materials needed. We shall need training material or information resources to support PR skill development. We need something to refer to like a manual that can be uniform all over Uganda. And we need commitment from hospitals, administration to set up. If we don't have a commitment of healthcare, hospital directors, executive directors, it may be quite difficult to implement these programs in various institutions. And it is the entry point to establish PR in various centers. How do we sustain it? We can sustain it by ensuring ongoing support for PR service delivery. It can be support supervision as people are implementing PR, or you can have visits and you see how they are getting on. Also can support training for more staff and advanced skills to existing staff through CMEs. That can be done. At some point, you never know that, I don't know, as of now, that even in Makerere students, they need to have some bit of a module about this animal called pulmonary rehabilitation. We have maintenance of referral systems, which are already there, and they know where and who to refer to be able to offer PR. What are the existing opportunities? Patient satisfaction. It's a very strong drive for us to continue giving this service and even train more to help those who are in need, and they know that they have high enthusiastic and they have good adherence as per the findings or in the previous presentations. We have the PR expertise in Uganda. I believe through the training and the partnership with the LISTA, the expertise in Uganda about PR is enormous. And I believe that even Uganda team has tried to give this person the same expertise to other colleagues as we see ahead. The engagement of policymakers is, they have high interest from policymakers to roll out PR. This was seen through the last PTLD care and rehab that was done, where NTLP, through Minister of Health, they participated, they collaborated well with the MRI to implement PR program. This is just one of the factors that we had training healthcare workers in post-TB. Because the theory behind is that if people can get very good formal training about PR, even if you were a nurse, you are, as long as you have some science behind about lungs and how lungs perform and how basic exercise prescription, those can be passed on. This was a planning and engagement to scale up PR, and a number of people who were there, also they are here. What are the challenges? One, human resource. Much as when it comes to exercise prescription, I think a physiotherapist will be number one to think of, but there are few physiotherapists in the country, and they are not in each and every facility. So we may not look at only at regional referral hospitals and district hospitals where physiotherapists, as of now, they can be appointed. The Center 4, Center 3, they are not there, and yet that's where the many patients could be. So we need to empower those healthcare workers to be able to give the service. PR is delivered as a team, and the team setup is not yet in place in many hospitals. It is not one-man show. And in MLI, we have Dr. Wincy, I'm there, we have a nurse, we had a social worker, we have quality assurance, all those things were there. So, sustainability, the service is still in the early stages in Uganda, so people may not yet understand it. So we need to blow the trumpet for them to appreciate. Also using those who are being our participants to be able to blow it for us. I usually say, I don't tell the patients how you are, is the patient telling me how he is, what has gained from whatever intervention it is. It's better heard than you, a healthcare worker. Lack of teams that continuously deliver PR, that can be an issue because some areas, facilities, healthcare providers can be transferred. And if they are transferred, that means they will leave a gap. Whenever they go, they may not have good partnership with a team that they can collaborate with to push PR. Time constraints. We know in life we have competing activities, and PR is delivered twice a week for 6 weeks, each session for 2 hours. Yes, it takes you your sacrifice to be there in those 2 hours because you are not only looking at only that activity. Employees find it difficult to afford the time. Yeah. That is also competing activities coming in. Stakeholders buy-in. What do we have to look at as challenges? Readiness of the key stakeholders like hospital managers, program funders, and sponsors. They have a total falling into this program to take it on wholeheartedly, but at the same time, among the indicators possibly in the Ministry of Health, possibly if they are put there, there can also be another issue to enforce that. The Global Fund recently funded a pilot PR study, pilot PR project to roll out PR and primary care workers. This was discussed by Mr. Mudashiru online, and he showed you the possibility, because now we are having the ideas that institutional vis-a-vis versus community model, what should we take up? And this was also raised that, yes, we need to think of what the patient is most comfortable with, not only looking at what we providers, what we are comfortable with. That's why Professor Sally was talking about introducing digital rehab program where people can look at what exercise to do and education to have so as to implement the program. That was the planning engagement to scale up. And those are stationary bicycles that we were given to various rest facilities, Kitebi, and others that Mudashiru talked about. I think that is all. Thank you for listening. I think next if there are any issues raised, we shall raise them later. Professor Sally is going to take us through setting up a pulmonary hub program. Let us wait for her.
Problems. So obviously we've been talking today about respiratory conditions, but people get breathless if they've got a cardiac condition. We've talked about people being unfit. If they're anemic and got renal disease, they'll be breathless. And of course, increasingly, and post-pandemic, we recognise that people that have long COVID or are struggling post-COVID infection, that they potentially also have breathlessness. So in terms of adding to the list, we've got all the sort of regular diseases, but I think now we're really considering post-TB lung disease, which is of course the focus of today, but also post-COVID syndromes as well. So I would add that to the list of common causes of breathlessness. So this is what I think constitutes a good rehabilitation program. I think you absolutely have to have strong leadership, and I think that the team that have presented today, you know, led by, you know, the clinical academics at the MLI, clearly have that drive to push forwards with pulmonary rehabilitation. And if you don't have that, it's not going to happen. So you absolutely need strong leadership. We've already heard that you need a well-trained workforce, but you also need a motivated workforce that want to do it and want to be involved in rehab. Has to be guided by the evidence, because if it's not guided by the evidence, it is likely to fail, and you want to provide high-quality care for patients. And clearly, if you've got a research active team involved in the rehab program, then that's even better if they're contributing to the data. You also need a robust data collection system, and we've talked already about standardized data collection, so that any of you that get involved in rehab can compare and contrast your data, so that you know what's working well and what isn't working as well. It needs to be timely. So in the UK, we have an audit process that gives us, essentially as service providers, 90 days from receiving the referral to when we should have offered a rehabilitation program. So it's no good if you're in your medical clinic saying, I've got the best treatment ever for you. We know that rehab works for post-TB lung disease, but I'm sorry, you've got to wait 9 months to a year to receive it. The patient automatically becomes demotivated by that, so it has to be timely. And then clearly you need strong patient engagement in that as well, and involve them in the formatting of the program. So we've already seen this morning as to what are the key aspects of a rehabilitation program, and I just would refer you to this document that we published in the annals of the ATS just before, well, just as the pandemic was happening really. It was developed pre-pandemic, but actually I think it still is an excellent reference document for what rehabilitation should look like and the key components of that. It doesn't matter within this framework how you deliver rehab, but it does matter that you tick all of those boxes that are identified as the essential components. And then the ATS have developed a little bit more evidence, but it was based largely on systematic review evidence. So it was developed very specifically to appeal to the American market and the American funders, which is obviously different to your funders and different to funders in the UK. And they had a number of PICO questions that they wished to answer. But there's some interesting ones there. So clearly, people with COPD should undertake rehabilitation, people with ILD should undertake rehabilitation, people with pulmonary hypertension should undertake rehabilitation. And as Bruce will know, there was nothing in there about TB, because he wrote a letter to the journal. So we're hoping that this evidence that's been generated from the team here will inform the next iteration of guidance, so that rehabilitation should be provided to people with post-TB lung disease, because it will be high quality data in the form of this randomized controlled trial. So the British Thoracic Society guidance is a little bit more practical. It's not a review of the evidence, it's a bit more of a how-to guide in terms of setting up a rehabilitation program and what are the key components. From the evidence, we're also in the process of developing quality standards, which really help services identify what they should be aiming to achieve. And they're sitting on my computer now, so they're almost ready to go to the Standards of Care Committee at the British Thoracic Society, and hopefully they'll be out for public consultation early in 2025. That's weird, isn't it, saying 2025 already? But I think it's a useful document just as a framework to understand what good quality rehab looks like. So key in the BTS guidance is a face-to-face assessment, which we've talked about, endurance and resistance training, structured education, core outcomes, and then an audit process to support that with this standardized data set. And it doesn't need to be complicated. This is quite a nice paper that was published in Thorax in 21, where they just compared their data where they'd offer rehabilitation in a community setting or a hall of worship where there was zero equipment available, but the team just took some weights, like you can see at the back of the room here, and set up a rehabilitation program. So it really doesn't need to be complicated. You don't need a sophisticated gym like the one they've got downstairs. So that would be a dream, but you absolutely don't need it. And the disadvantage of having a gym or doing rehab in a gym like the one you've got downstairs is that people only associate doing exercise with coming to the gym. And obviously we were talking before lunch about how important behavior change is. So if you have a program based on something really simple like walking, that's easier for everybody to do. You don't need exercise equipment to do that. So I think there's a lot of positives in making it simple. I think it's probably more sustainable from a patient point of view. But obviously, however marvelous a rehabilitation program is, unless you have a good referral process, it sort of doesn't matter. So all of the medics in the room have to be aware of what rehabilitation is. And when we survey people, there's a lot of uncertainty about the value of rehabilitation. So although, all of you in this room now know how marvellous rehabilitation is, and we heard from the patient that took part that it was marvellous, unless a referrer knows how marvellous it is, they're not going to refer in. So there's work to be done in educating all of the teams in clinics to advocate for rehabilitation. And you can see here that both in Sri Lanka and in India, there were some concerns about not understanding the value of rehab. They didn't have enough information, and actually they didn't know how to refer. So these are the fundamentals that you have to get right if it's going to work and work at scale. And this was some data from the UK where they put in a respiratory specialist into primary care, and just to make the point that you can see where I've circled, nothing else really changed apart the number of referrals to rehabilitation went up as soon as you put in a respiratory specialist into primary care. So just knowing about rehab and referring in is crucial. So we've also talked a little bit about one size may not fit all, and I noticed yesterday when I was at the MLI that the sign across the top says cardiac and pulmonary rehabilitation now, doesn't it? So clearly there are opportunities to rehabilitate many other long-term conditions, because as we saw from the previous slide, or the first slide, people get breathless for all sorts of different pathologies. So this is just some work that we've been doing in Leicester that is digital. We have a digital program for COPD, we have a digital program for post-COVID, and we have a digital program for cardiac disease. You can see at the bottom called Activate Your Heart. And we've now integrated all of them into one website. So if somebody has a cardiac and a respiratory condition, they can use the educational content at the back end of this single website. And we think we can extend the scope of pulmonary rehabilitation. So this is data looking very specifically at people with heart failure. And you can see that if we look at people with heart failure that take part in a pulmonary rehabilitation program, so we actively recruited people with heart failure, not people that had comorbid heart failure, but genuinely had heart failure as their primary diagnosis. You can see on the left-hand side that their response in terms of exercise is exactly the same. So I think there are real opportunities to increase the scope of rehabilitation beyond just pulmonary rehabilitation. And I think when you're developing services, you are very well placed to address some of the challenges of people with other long-term conditions. And this is data from our COVID rehabilitation program. So you can see on the left-hand side, we have people that followed a face-to-face program, and on the right-hand side, people that followed a digital program. And this was a randomized controlled trial. And you can see that both forms of rehabilitation added value and achieved the minimum clinically important difference. The digital program was slightly less effective than the face-to-face, but I guess you'd assume that because the contact and the supervision is less, but nevertheless, the digital product did achieve the minimum clinically important difference, so patients got benefit from it. So what next? In everywhere is challenged by people with multimorbidity, aren't they? And you're no different to us in the UK. And I know that Felix is going to talk about this in a minute, so I'm not going to dwell on what multimorbidity is, because I suspect Felix will do that, but we all know it's 2 or more long-term conditions. And one of the pieces of work that we did was to look at the evidence around exercise as an intervention for other long-term conditions over and above COPD, which is obviously where we all feel very comfortable. And you can see here on the right-hand side of this graph or bubble plot that there is a huge number of long-term conditions where exercise is of benefit. So in the UK, we are now looking at combining rehabilitation so that it is not cardiac rehab, it's not pulmonary rehab, but it is for people living with multiple long-term conditions, which essentially is everybody. So I suspect you don't see many patients with post-TB lung disease that actually don't have something else as well. So I think the ethos around acknowledging those other long-term conditions is probably sensible and probably cost-effective. And then just a little bit about audit. I think it's important to have a standardized data set so that you can benchmark your service against other services and understand what, as a country, is your minimum standard. So I talked about us having to see patients. One of our standards is seeing people within 90 days of referral. But that's obviously negotiated with government separately or your health authorities. And we also have now an accreditation program. So we have a peer review process to make sure that the program that we are offering is a good standard. And we set this up with the Royal College of Physicians in the UK. So they have supported a pulmonary rehabilitation accreditation scheme. So we have quality standards that drive the audit standards that then inform the accreditation scheme. So we have a complete wraparound set of defining variables looking at high quality rehabilitation. So in summary, we all know that pulmonary rehab is an effective intervention. I think we've heard that consistently today. There's clear evidence and guidance for the delivery of rehabilitation. And it doesn't have to be difficult or complicated. I think we all imagine we've got to have something just like the gym downstairs, and we don't. I think it's important when you're spending time developing the intervention, you also consider the referral pathways in, because if you don't have a good referral pathway, nobody's going to make it to your door. And I think, we've seen from all of the research studies that have been presented, collecting and routinely analysing data is really important to maintain and support the delivery of high quality care.
Thank you, Sally, for the wonderful presentation. And those who have questions, please, you can write them down as we shall ask them later. The next presenter is Fanuel, who is our friend from Malawi, and is going to share his experience of patients with pulmonary rehabilitation at a referral hospital in Malawi. Kindly, come and
thank you. So I'm indeed Fanuel Bigton. I'm from Malawi. I've traveled with Dr. Felix Limbani. I am a physiotherapist by professional background. I was trained at the University of Malawi College of Medicine. It is now known as the Kamuzu University of Health Sciences. After I graduated, I developed a strong interest to specialize in one of the fields of physiotherapy known as cardiorespiratory physiotherapy. So I wanted to be a cardiorespiratory physiotherapist, and I've always been passionate about research. So for me, I had to identify an environment where I could grow as a researcher, as well as to craft a research area that I was interested in. So after finishing my physiotherapy clinical internship at the largest referral hospital in Malawi, Queen Elizabeth Central Hospital in Blantyre, I applied for a research internship at the Malawi River Wellcome Trust Clinical Research Program. So this is a research institute that is affiliated with the university. So all they do there is research, clinical research. So I applied for a pre-master's. So to prepare me, apply for a master's. So when specifically at the Malawi River Wellcome Trust, I joined the Malawi, one of the research groups there, known as the Lung Health Group, because my interest was in cardiorespiratory physiotherapy, something to do with the heart and the lungs. So I deliberately joined the Lung Health Research Group. So my then mentor or supervisor helped me come up with a research idea. He actually attended, there was a lung conference here there at the Makerere Lung Institute. So when I was trying to search what I could craft as my research path, one of the presentations at that conference was the first or initial pulmonary rehabilitation research project that was done by the Makerere Lung Institute team. So when he came back to Malawi, he talked to me about it, and I was interested in it to say, I think this is what we have also to do for Malawi. So that's when my research idea was born in pulmonary rehabilitation. So I read about it, and I found that it was indeed a necessary intervention, considering that there's a huge burden of chronic respiratory diseases, with COPD being the third leading cause of death. And I read the literature. There was high quality evidence of the effectiveness of pulmonary rehabilitation as an intervention for patients with chronic lung diseases. But I had just graduated from the university, and I had only theoretical knowledge about it, because in the university, we only learned about the theory of pulmonary rehabilitation. We didn't have, even during our clinical placements, we didn't have I didn't experience the practical, I didn't have the practical experience of pulmonary rehabilitation. So my mentor and I decided that I come here to learn from the Malawi MRI team. So I remember I came in 2018. I joined the sessions by Richard Casita, the physiotherapist who was learning the research. Okay, right. So I joined Richard Casita's sessions of pulmonary rehabilitation when they were running their research project at MRI, so that I could learn and have the practical experience of what the pulmonary rehabilitation sessions look like. So that was helpful. I stayed there for 1 week, and then I applied for a small grant to get started with my pulmonary rehabilitation research projects in Malawi. So I won an Early Career Award grant from the Royal Society of Tropical Medicine and Hygiene, funded by the NIHR in the UK. That was around £4,000. So it helped me put my pulmonary rehabilitation team in Malawi at Queen Elizabeth Central Hospital, the largest referral hospital in Malawi. And we started recruiting patients. Yeah. And then COVID came, so our program was categorized as one of the high-risk studies, because we are dealing with patients with already compromised pulmonary function who could be exposed to COVID. So it had to be suspended. But fortunately, at the same time, I won another grant. This was to help me do this systematic review, as well as go for my master's studies in cardiorespiratory physiotherapy, the field that I was interested in. So that time of COVID-19 was kind of buying time for me to prepare by also acquiring more knowledge and skills in pulmonary rehabilitation from my master's studies. But I also managed to do this systematic review with mentorship. This was a systematic review to explore the evidence for pulmonary rehabilitation in this region of Southern Africa. So we see that out of the 6 studies that we found in literature for Southern region, there were only 3 countries with evidence. And that time Uganda had just completed their first pulmonary rehabilitation trial. It was non-randomized controlled trial, but they at least had evidence. So it was one of the 3 countries that had such evidence, in addition to Nigeria and South Africa. So the evidence was really in just these 3 countries. There was none from Malawi. So I was motivated to do something for Malawi to close the research gap that we had. So I won the NHR Welcome International Masters Fellowship to pursue masters in cardiorespiratory physiotherapy at the University College London. So that's me there. And one of pulmonary rehabilitation is one of the modules of the program. So I remember visiting the pulmonary rehabilitation clinic at the University of Leicester, where Professor is based. I also had a practical feel of, I was involved in their practical pulmonary rehabilitation sessions. And during my master's studies, this was my master's thesis, which was published, I explored the barriers and enablers because I looked at the evidence throughout my systematic review that there was little done in our low-income countries. So I hypothesized that maybe there were some unique barriers facing low and middle-income countries because even when we look outside Africa, there were very little evidence coming from other low and middle-income countries. So I hypothesized that there would be some unique barriers that were challenging the implementation of this important intervention. So I interviewed, through in-depth interview, some structured in-depth interviews. I collected data from participants from Latin America, Argentina. In Africa, I interviewed physiotherapists from Zimbabwe, Malawi, and South Africa. And in Asia, I interviewed participants from Kyrgyzstan and India. So, as you can see, they told us about many potential barriers and enablers. And it was at the time of COVID-19. So COVID-19 actually was one of the barriers because it meant the closure of some of the pulmonary rehabilitation clinics that were going on. They were suspended. But the most important challenge, which also I think has come up, has been presented in the previous presenters, was the issue of unlimited human resources. So properly trained physiotherapists in pulmonary rehabilitation was not there in many low and middle-income countries. On the enablers side, COVID-19 was at the same time an enabler because it meant shifting from physical pulmonary rehabilitation sessions to online. So it kind of like it was a boost for the online or tele-based pulmonary rehabilitation, and providing this training to healthcare workers such as physiotherapists, formally integrating the pulmonary rehabilitation education in our universities was one of the potential enablers. So I presented these results at the University of Leicester. So this is at the University of Leicester where Professor is based. I was presenting these results and I was also presenting my plans for Malawi when I come back from my studies. So together, we put up a protocol for the development of pulmonary rehabilitation in Malawi, and the research team at Leicester, they helped us quite a lot with their input to the development of the protocol. We tried to be systematic about it, so the first thing we did was to explore what would work in our setting in Malawi. So the first preliminary study was to gauge from participants as well as their caregivers, how should this program be implemented for it to be acceptable and feasible to them. And some of the issues that came up was the need for transport, because these were patients who would have to be traveling long distance to access the intervention at the hospital. So likely it was a funded study, so we were able to provide transport. Some participants said maybe especially the female participants, they said they would like if they split. Some did not like because we were to author it, deliver it in groups. So some were not comfortable with mixing men and women. So we decided that maybe we'll have to split, but we found out that when we were implementing the actual intervention, it no longer became an issue. So they were actually comfortably mixing. Yeah. So this was just an overview of our intervention. As is the norm was the standard for pulmonary rehabilitation. We did a baseline assessment, then we delivered the intervention for 6 weeks, and then we did the reassessments to find out what had changed. It was a very small study. Only 10 participants participated, and it was non-randomized. What we wanted actually was just maybe the feasibility and acceptability of it. Those were our primary outcomes. So you can see that these were the assessments we did. We did anthropometric measurements, spirometric measurements, assessment of breathlessness on the modified medical Disney Research Council scale, the COPD assessment test, the hospital anxiety and depression scale, the checklist individual strength scale, as well as the incremental Shattergold test. So we are still in the process of analyzing this quantitative data, but what we have finished is the analysis for qualitative interviews. We asked patients at the end of the 6 weeks, what had changed by participating in this 6-week program? So this is just a summary of the characteristics of our participants. So there were 10 of them. As was the case with the Ugandan trial, there were more females. It is also an issue in our setting. I think females are good at seeking healthcare than males. So we have 60% were female participants, the women. And then, as you can see, they are ranging from 24 years old up to 82 years old, average being 49 years. So similar experience with the, I think, research project here in Uganda. And you can see that the respiratory conditions that they had, so we're recruiting anybody, post-TB, COPD, bronchiectasis, where as long as they had a respiratory disease recorded in their health passports. So you can see that among our participants, most of them had post-TB actually, meaning that this post-TB lung disease is a burden in many countries, including other countries in this region of Africa, including Malawi. So you can see several participants having post-TB, but in addition to those primary lung conditions, you can see in the last column, they are having also other conditions, like HIV, hypertension, pulmonary. Yeah? So that the issue of morbidity that Sally touched on. So we have completed the manuscript for the qualitative data, and it is currently undergoing peer review in the BMJ Open Respiratory Research Journal. But it is also available online as a preprint. It was posted on a preprint server. The themes that came out were 5, but in this presentation I only present 2, focusing on the prior experiences of participants before participating in the program and their experiences after participating in the program. So we see that film number 1 is talking about the physical issues that these patients were experiencing. This is a post-TB, this is a patient living with post-TB and HIV, 27 years old, a female. She's talking about how before participating in the program, she couldn't wash or do activities of daily living. So physically, these participants were experiencing physical challenges in their performance of daily activities of daily living. Psychologically, they were also affected. Before participating in the program, participants talked, like this one is talking about how she used to feel anxious. She was uncertain about her prognosis of the condition. So this was another post-TB patient. She had received and completed the drug regimen for TB, hoping that she would be better after that. So she was still asking herself questions like, I finished the drug regimen, but I am still coughing, I'm still experiencing breathlessness. So she was like depressed. And this one is talking about how socially she was affected. So even a simple task of laughing when she was together with friends, she couldn't hold the laugh because she became breathless. So socially affected. Sleep quality was also disturbed. This one is talking about coughing a lot at night and having breathlessness. And this was a patient with post-TB, COPD, pulmonary, and hypertension. So lots of conditions are documented in her file. After participating in the program, it was now a change. This patient is now talking about being able to do laundry. She could wash the clothes. And socially, this patient is talking about the romantic attention now she was getting from even men. Like before attending the program, she was like weak. Nobody could approach her, no suitors. But after participating in the program, she's talking about how she started receiving lots of, romantic interest from men. So she was narrating that story. And psychologically, there was reduction in symptoms of stress and depression. So when I came here after the pulmonary rehabilitation program, I put aside many anxieties. So this patient had experienced a reduction in symptoms of anxiety. Sleep quality, they could now sleep better without breathlessness or coughing at night. Even the use of inhalers that they were initially using before pulmonary rehabilitation reduced. So this patient is talking about how initially she was frequently taking inhalers. But after undergoing pulmonary rehabilitation, she experienced like she could no longer need frequent use of those inhalers, and she could visit the hospital less. Yeah. So our patients that we have looked so far were having post-TB, COPD, bronchiectasis, but we also had COVID-19, and I'm sure you might have heard of long COVID or post-COVID-19 syndrome. Yeah, and I think it's an interesting area of research that we have to explore, because we do not know what is happening to the survivors of COVID-19. They might have not been presenting to the hospital because of anxiety, of maybe the stigma that they may have of being, they may be associated with being infectious. So maybe they are suffering in silence, but a tsunami of rehabilitation needs in the survivors of COVID-19 has been reported in other countries, especially in high-income countries. So we had such a patient in Malawi. Actually, this was the first case of a successfully medically managed patient published in literature from Malawi, from Queen Elizabeth Central Hospital. So after this patient was successfully discharged from the intensive care unit, the medical team referred this patient to us, the physios, to manage her, to rehabilitate her, because after the 3 weeks or after a month or so, he was still experiencing cough, shortness of breath, and fatigue. So we delivered an online, based intervention. So it was very improvised. We used WhatsApp as well as Zoom. So this was a patient who had at least some access to technology, fortunately. So we're delivering it online because it was a time of COVID-19. And we delivered the intervention for 3 weeks, 3 days per week. And we incorporated the breathing exercises, aerobic exercise training, as well as strength training. We also offered education to him on the pathophysiology of COVID-19, linking that pathophysiology with the symptoms that he was experiencing. So as you can see, this is in his room. He's doing a goblet squat with some fruits, filling with a basket filled with fruits. So it was really improvised because there was no equipment. So he was lifting up and down the way he would lift dumbbells in the gym. And as you can see, we had 3 measures, outcome measures. We had the Disney scale, the modified medical research Disney scale. We also assessed his quality of life using the COPD assessment test. So we had to borrow outcome measures from the famous COPD. And then the checklist individual strength fatigue scale assessed his fatigue. So you can see that before undertaking the online rehabilitation program, the numbers changed. For example, for Modified Medical Research Council, MMRC, from 3 to 1. And I have put down the notes to say if there is a change of at least 2 on the Modified Medical Research Council, actually 1, then that is a minimal clinically important difference. As you can see, also even for checklist individual strength fatigue, cis fatigue, the minimal clinically important difference is 9, and you can see that this patient, before undertaking the rehabilitation program, he was at 43, but after the undertaking the program, he was at 11. So that was a difference of more than 9. So that was a minimal clinically important difference to him. So the key messages for Malawi is that we have also seen that PR is feasible and acceptable, but barriers include limited human resources. We need to offer more training, and I'm using my opportunity as a lecturer at the University of Health Sciences to start lecturing to our undergraduate students pulmonary rehabilitation. Starting at in year 2, I focus on teaching them about COPD, like the pathophysiology of the conditions, bronchiectasis. Then in year 3, I teach them about assessment. So when they start going to the hospital in year 3. So what we are focusing on, are they able to do a thorough assessment of a pulmonary rehabilitation? Then in year 4, they start practicing it in their clinical placements. So by the time they are graduating, we hope that in the next 5 years we'll be seeing lots of physiotherapists who have the skills in delivering pulmonary rehabilitation. Yeah. So my colleague now will talk about the rest of the presentation. Felix.
No, it's a continuation of this. Yes. Good afternoon, ladies and gentlemen. So my name is Felix Rimbani. I am a social scientist. So I don't know anything about PR. I don't know anything about lung health. I don't know anything about rehabilitation. But here I stand as the group lead for the lung health research group at the Malawi Liverpool Outcome Program. But I also coordinate what we call the Africa Multi-Mobility Alliance. And this comes from a background that I am a lead on one major project that is happening in Tanzania as well as in Malawi, and it is on multi-mobility. We are looking at acute patients that are presenting to our hospitals. How do we effectively screen for multi-mobility? How do we provide the relevant treatment? And how do we link them to ongoing care? So I'm here to talk about pulmonary, from pulmonary to multi-mobility rehabilitation, because this is work that is coming out from the African Multi-Mobility Alliance, which I am coordinating. But there are several members that are part of that alliance that are here in Uganda, as well as Sare and others are also part of the alliance. So I would like to give a brief background to the work of the alliance, but again, the idea of about thinking about from pulmonary to multi-mobility rehabilitation came about. So probably Sare said everything that I wanted to say, that if you look at the multi-mobility is a challenging problem, is a big problem now among our health systems. The clinicians that are here will agree with me that we are now moving towards seeing patients that have got multiple long-term conditions. The word multi-mobility, MLITC, is a word that is currently interchangeably used. People would refer multi-mobility as coexistence of 2 or more long-term conditions. Others would look at it at multiple long-term conditions. But yeah, that's the challenge that we have at the moment. And the challenge, especially with our health systems, is that it's donor-driven and donor-dependent. And we are coming from a background that our services are vertically organized. So if there are clinicians that are responsible for a particular disease, if it's diabetes, patients who come for their diabetes clinic, if hypertension, we are moving towards integrated care, but this is the background that we are coming from. So looking at that, I think there's need for responding to multimorbidity, and it requires a paradigm shift from a disease-specific to a person-centered care, so integrated care for chronic disease management. Discussions about multimorbidity have been there for some time. There was one from the Academy of Medical Sciences around 2019 that looked at what are the priorities that we need to think about when it comes to addressing multimorbidity. So issues that came up, the need for a holistic but also integrated care for patients that have got multiple long-term conditions. And to achieve that, there is need for collaboration across disciplines as well as institutions, so that patients are seen as a whole than compartments according to their specialties of the clinical team. So it is against this background and discussions that has been there or was there among different researchers, but again among different people, that we thought about coming together and discuss about multimorbidity. And around this time, around 2 years ago, we convened about 60 researchers, practitioners, as well as different stakeholders. We convened in Malawi to discuss the concept of multimorbidity, as well as how this can be looked and championed in the sub-Saharan Africa. So discussion around that was about concepts and framings, how people would view multimorbidity. If we are to go towards integrated care, what sort of concepts and framings would people attach to treatment and management of multimorbidity? What sort of data and infrastructures that are already existing within ministries, within universities, academic institutions that we can utilize and better approach multimorbidity? Risk prevention, but again upstream interventions that are already there on the ground, and those that we can think about to champion multimorbidity management. But again, look at how our health systems are set up and the care models that we can think about. So this, the discussions was around these themes and how what needs to be done. Out of that meeting, we agreed of a community of practice to establish the Africa Multimorbidity Alliance with different working groups that are focusing on those 4 themes that I've talked about. But despite that, over the years, two years down the line, the grouping has grown to about more than 100 participants, members, covering different regional expertise across Africa, but as well as different disciplines and different research groups. And within that, there's special interest on rehabilitation, and that's work that Sare motivated most of us, that why can't we start thinking about multimorbidity rehabilitation? Because we've talked about rehabilitation in terms of health systems, rehabilitation in terms of different different concepts, but what about rehabilitation in terms of multimorbidity? And this necessitated to kickstart a working group on multimorbidity rehabilitation, and this was basically because of the area background that I've talked about, that multimorbidity leads into physical function and associated with the mobility and the disability. But again, we know that rehabilitation is usually structured in silos according to disease specifics. But as we've heard since morning, when patients come, they would come with a primary condition, but there are several other conditions that patients will come with. That's the data I've seen in the morning, and Fanuel also talked about it. And how can we think about rehabilitation with a concept that this patient has got multiple long-term diseases, rather than just focusing on specifics, for example, cardiac and pulmonary. But again, as I said, in our everyday practice, patients who attend rehabilitation programs have got other coexisting health conditions. So single disease rehabilitation models may not be appropriate for the people that we've talked. So since morning, I think the discussion has been about single disease, but it's time that we move towards multimorbidity rehabilitation. So there is two work that we are championing through the Mobility Alliance, and luckily Fanuel, as a physiotherapist on that, is leading two projects that would want to champion across the sub-Saharan Africa. And I would do injustice if I talk about his programs on his behalf. So let me just invite him to quickly talk about those two projects that he's championing.
Yeah, so this was already presented. As you can see, the conditions highlighted in yellow were other conditions that we saw in patients with different chronic respiratory diseases in our pulmonary rehabilitation programs. So that's why also the motivation to do something that encompasses different conditions in these patients, known as multimorbidity rehabilitation, is coming from. So that's why we need maybe to kind of shift from pulmonary, which is a single disease specific intervention, to those with multiple, because it's rare that patients with that would benefit from pulmonary rehabilitation would present with only one condition. So the first, for my PhD proposal, I am proposing something inspired by the what we call the PERFORM trial that the Leicester studies team in the Leicester are doing. They are trying to come up with a personalized exercise-based intervention for people with multiple long-term conditions. So I am proposing a type 2 hybrid effectiveness implementation study to co-design with service or with stakeholders a personalized exercise-based intervention for people with multiple long-term conditions. So in short, we are calling tentatively the DREAM trial. And in this DREAM trial, we'll try to answer these questions. What are the rehabilitation needs of people with multimorbidity in Malawi? So we'll do a secondary analysis of the MatLink data, of which Felix is a co-investigator. They have done studies on the prevalence of multimorbidity in Malawian hospitals, the common clusters or patterns of multimorbidity. And I'm going to do a second analysis of that data to see if something that shows that these patients have rehabilitation needs. So to answer the first question. And then the other question is, what are stakeholder perceptions on the proposed DREAM intervention that we're trying to design, that exercise intervention, and what is its effectiveness, but what some of the factors that can spearhead its implementation. So that's why it's a type 2 hybrid effectiveness implementation study, because we want to also look at effectiveness, but also how we can implement it and scale it up in Malawi. Yeah. So this is an overview of a DREAM study. The first stage will be to identify patients who could benefit from pulmonary rehabilitation, so those with rehabilitation needs, by doing a secondary analysis of the MatLink data. And then we'll discuss in the middle there with stakeholders, including patients with multimorbidity themselves, their caregivers, as well as policymakers, on the design of the intervention, its acceptability, as well as their insights on how we should deliver it. Then lastly, we'll conduct a randomized control trial, and we'll deliver it in two settings. So we'll deliver it at homes of the patients, because as you can see, the evidence that's coming from the Recharge project, we need to take this intervention closer to or near to where the people live. So we cannot just continue doing it in the hospitals. So the idea of having some patients doing it at homes is that we need to find out immediately after the end of the study, what factors or barriers or enablers are there for conducting a home-based multimorbidity rehabilitation. But of course, we also have another group that will undertake it at the hospital. And there will be another group that will be receiving their usual care, so a bit like the medications or whatever interventions that they receive from the physician or from the clinicians. Yeah. And this is a second PhD proposal, like another component. So yes, we know, like in pulmonary rehabilitation, we have outcomes that we measure, like the incremental shuttle test. We are trying to measure the distance that is walked on that test. The health-related quality of life instruments, we have them. But for multimorbidity rehabilitation, because it's an emerging area, we do not know, there is like lack of consensus on what should be measured or what matters to patients with multimorbidity and other stakeholders. So there's kind of heterogeneity in the literature, and that is making it difficult for systematic reviewers to synthesize data on multimorbidity or evidence on multimorbidity. So we are trying to come up with those core outcomes or key areas that should be measured, or including the instruments that can suit the measurement of these outcomes through this project. And as you can see, we are trying to base this development on the ICF framework. This is like the Bible for physiotherapists and other rehabilitation professionals. Like whatever physiotherapists do in a clinical setting, we do it according to the World Health Organization's International Classification of Disability, Health and Functioning. So we are trying to develop the core outcomes or core sets, the ICF core sets based on this framework. So that way we'll be able to know exactly what matters to patients with multimorbidity as well as other stakeholders. The ICF in general, or its overview, it says that functioning is a key area in any person. So it is affected by many components, including the environmental factors, the interaction between the environment and the impairments, activity limitations, participation and restriction, and that's what we are going to base our ICF core sets. So it's a project which has guidelines to develop the ICF core sets, and this is an overview. It was published by Seb and colleagues in 2015. The development process for developing the ICF core sets. So in phase 1, we are going to do 4 international studies, including an empirical multi-center study, a systematic literature review, quantitative study, expert survey, and then we are going to come up with a list of candidate categories that should be of focus for people with multimorbidity from that phase. We are going to do something similar in the next phase. So this is going to be an international consensus conference whereby we are going to present the results of the 4 studies here, and we are going to ask experts to vote for the key concepts that should be measured. And then finally, we are going to validate our ICF core sets. Then I invite again Felix to finish this slide. Yeah. Thank you.
So just to finish, I've got a few slides really that will probably provoke some discussion. I'm sure you've got lots of questions already from what you heard this morning and this afternoon, but I'm just going to put up a few slides, or hopefully I'm going to put up a few slides. The font's changed, so that's interesting. I don't quite know how that's happened. Anyway, hopefully the words haven't changed. So I think what we know from Recharge is that pulmonary rehabilitation is hugely effective. Availability is very limited in lower middle income countries, but there is early evidence now and compelling evidence in a post-TB lung disease population that rehabilitation is effective, and obviously we're all working very hard, Wincy, aren't we, to get that in the public domain and get that published so it can be referenced in the guidelines. So I think the challenges are really what we've heard today. It's really around dissemination of the results, informing policy so that these sorts of interventions are embedded in national guidance so that people can benefit. We can spread it and look at adoption, potentially looking at alternative modes of rehabilitation. Richard talked about workforce training. And we've just heard about other populations. Should we be looking at rehabilitation for people with multiple long-term conditions? And we were challenged last night when we were out at dinner that we really do need to consider children and young adults that have post-TB lung disease. So I think now that we've established conceptually that it works in adults, and some of the adults that came to the trial were quite young, I think we now need to look at young adults and possibly look at a trial in, you know, children that are 12 plus and try and adapt what we know works in younger adults than we see in the UK, whether that would work in children. I think that's been a neglected area for an awfully long time. So I definitely listened to people at dinner last night, so I think it is an important and emerging area. And of course, these children have their whole lives in front of them, so I think it would, you know, the earlier we can intervene, probably the better. We know some of the challenges are around people understanding what rehabilitation is, and this was a, you know, Fan Wells showed this graphic, and hopefully it'll be useful, because I think we had all sorts of problems with the ethics committee locally, didn't we, thinking that rehabilitation was simply chest physiotherapy to remove secretions. So this sort of article and flyer really came out of some of the challenges we had with ethics committees, so people would understand what rehabilitation was. And I think we've talked before about referrers' knowledge is absolutely crucial to referring patients in. So hopefully these sorts of initiatives will be valuable. But we do have to win over hearts and minds of people like you to refer patients into services. We've talked about digital options. Is there something we could do in the post-TB lung disease space that might work? We've used this in India, and this wasn't a randomized controlled trial, so this is a bit of a teaser really in a way. This was a cohort trial, but very similar to the data from Uganda. We had a high uptake rate and a high completion rate. So clearly the intervention was acceptable to that population. And you can see on the left-hand side, I've got the data pre and post for the shuttle walking test, and the magnitude of change is even greater than the one we saw in the post-TB population. And whilst the graph has gone down, what that means is people's perceived quality of life got much better. So this digital intervention, you know, in this population, this was 40 people, they improved significantly. So that gave me faith that for some people a digital intervention is the right thing to be doing. We've already seen that there are digital options for people with other respiratory diseases, which plays to the whole multimorbid arena, that we may be able to develop something that addresses symptom burden alongside disease education, because I suspect, as we've already seen, people get breathless for all sorts of reasons. And can we extend the scope further? Should we be looking at multimorbid rehabilitation? Because we know, and we heard this morning so beautifully from the lady that had gone through the rehabilitation program, that exercise should be considered medicine. And I think we need to have a shift away from not really understanding rehab to really respecting what it can deliver. So I'll leave all the challenges up there. They're just a repeat of what I said, and they may help stimulate yet more questions, but hopefully a few solutions in the room as well. So thank you.
Thank you, Sally, for that good presentation, where digital PR is, I think, the way to go, but our country, Uganda, where internet and other people have this button phone might be an issue, but it's something all that discuss. Those are challenges depending where we are. As of now, we seem to be getting on well with the program, and I shall ask to have some questions for the previous presentations, and they are responded to. Any questions, please? Any questions?
Thank you, Susan. Once again, I'm very passionate about pulmonary rehab, because all my patients who cure from TB, when they are discharged and they go home, and they have any ailment, they will come back to the TB ward. Yes, because that's what they know. So I'm very excited to hear that there is effort, a lot of noise is being made, and PR is coming on board. So what's the plan? What's the plan in terms of implementation? So that's what I want to hear, the discussion starting. What are we going to do to scale it up to whoever needs this service? Thank you.
Any other question, please? I think that question could have been directed to the...
I think, number one, my question was answered by one of the presentations, because in Uganda, or probably other countries also suffer it, we tend to give medicines to patients and leave them with whatever side effects, and that is the real key thing which we don't handle. So I am happy we are talking about lung health, and it started with TB, post-TB lung disease, but there's so many things affecting the lungs that actually go beyond the lungs, including the whole body, that comes as a lung but masquerades as a lung, but the people are affected and quality of life is really low. So I appreciate the fact that we have been able to move from post-TB lung, and I've seen those presentations on multiple morbidities around the lungs, the heart, all that stuff. And probably from this forum, can we take it on to, I know there are physiotherapy sessions sections in the country, but to all of us who are clinicians here, how effective are those, and how many are benefiting from them, and how many people are there possibly crippled or not working because we have not been paying attention to that side of things as clinicians. So it is huge. As we can see just from TB, the quality of care is poor there, probably because we've not been giving support and paying attention to that. So my other question, which was going to come, was how about the other conditions that affect the lungs? That has been answered here. But again now, I might come with poor breathing, but this is the problems affecting all my other body, including the walking and all that stuff. How are we going to collaborate or integrate this into the existing physiotherapy plans in Uganda? And how are we going to move this thing really forward to the ministry? As we are here, of course, for people to understand that quality of care is actually after the medicines. Starts after our medication. Maybe before, but after you've given your Panadol, the patient remains with, if it was a crippled leg or knee, it will remain there and they will not walk if we do not support that other section. So it's just a comment and a question to all of us. How can we move this? For TB patients, we are passionate about this. we want to see how we can actually move it faster, because after taking DRTB drugs for 9 months, that's the shortest for now. We are of course going to move to 6. How about the quality of life after that? So thank you so much, and I hope we can have a discussion around this.
Thank you. Any other issue to raise that we can discuss? Dr. Aldo.
Yeah, thank you. Mine is a brief one. Thank you so much for the presentations. I'm thinking so hard about this multimorbidity. From the presentation, I was trying to pick out the specific multimorbidities that are associated with the post-TB lung disorders. And I want to know if it's the TB, previous experience of TB, that predisposes them to get the other conditions, or because we also have the NCDs, which also come over time. So I just want to where's the line? Where do you draw the line between post-TB lung disease with other multimorbidities, other conditions, and also these other prevalent NCDs that like hypertension, hypertensive heart disease, and these other conditions? Does it worsen their outcomes, or which one comes before the other? Anyway, I just need more light. Thank you.
Doc, any other issue to raise? Dr. Emma. Yes, please. Okay, thank you.
Thank you so much for sharing a lot about the rehabilitation, post-lung. Now we have heard about also the cardio disability. I think the questions Rose and Susan are raising, I hoped that they could also answer some of those questions. So at the end of this research, I'm thinking we are supposed to be drawing an action plan of the way forward on how this, what we have learned today, or what we have known through the research that we have conducted, and what is going on in Malawi and maybe some other countries, the learnings from there, how do we get them into our health service delivery system? Definitely what Mudashi also presented might inform. It will be helpful, I think, to think through how do we get out of the research into the programming aspect. How do we build capacity for the teams that are out there? We know that what is available within our health sector. That bit about the physiotherapists that are available in a number of regional centers, not exactly lower than that. How do we get them to know that this is something that they should be looking at, and then prepare adequately for that? I think that's the kind of discussion we should be having. Yeah, thanks.
I think let us leave the, Professor Bruce will give highlight on the questions given, as well as Dr. Emma on the way forward. Thank you.
Thank you, Sita, who is also our chair. Susan, the question you have raised is very important. How do we move forward from here? We already have a scale-up plan. We already have training materials for post-TB disability care. What we are looking for now is just resources to train more healthcare workers, and we plan to start from the regional referral hospitals according to our plan. But the ultimate goal is to have a low-cost pulmonary rehabilitation that can be provided by frontline health workers. Yeah, maybe Professor Bruce may add on, but we already have a scale-up plan as a program. Thank you.
Thank you. I think we actually moved ahead of this dissemination, as you know. In the morning, Susan, I outlined what we've gone through to get where we are, starting with records review of the things we are talking about in the TB ward, to the single arm, to a small non-randomized to randomized up to where we are. Where we have now randomized clinical trial evidence of the benefit of pulmonary rehabilitation in post-TB patients. When we reviewed the literature, when we were starting, there was one case report from Japan, yes, which had tried to see if PR works in post-TB. Now, in medicine, as you know, just because this thing works for COPD, you can't just transfer it and put it on post-TB. That's what we have been doing in the last 10 years, struggling with. Now, with RCT, which was presented, beyond reasonable doubt, PR works for post-TB. Even before this dissemination, we worked with the Global Fund. Susan, in your absence, we worked with the Global Fund to develop a low-cost primary care pulmonary rehabilitation package funded by the Global Fund. That's the PAC project which Mudashir presented. We completed it. You saw the results. Not as good as the ones in the RCT, but there is still benefit. Yeah? So now, what we need to do is how do we cascade that low-cost PR? Of course, if you are in Mulago, for you don't go for low cost. You implement this little thing here, the little package which we have tried. But the low cost will now go to Regional Health Center Fund District. Global Fund, the program manager is not here. I don't know whether Dr. Luze is still here. I think he has also left. Dr. Raymond? Global Fund, actually. Yes. Yes. The Global Fund is willing to scale, and we have a scale-up plan. What has happened since we finished in July, August, we have been now working on the paperwork. Actually, we have a meeting, I think, next week or the other week. So Global Fund, as part of the country Global Fund budget for the active TB, is going to include something for post-TB. And I think this is a huge success if it happens, because Global Fund funds TB almost in the whole world. So if they fund it here, then the other countries will also start what? Applying. And I think for us as academics, we are actually almost, we want to smile to the next problem. You know, for us, that's what we do. We can completely lose interest in this one. We leave it with you guys. Yes. Then we develop interest in another. That's why people ask me these days, why are you not working on air pollution? I don't know, air pollution I finished, I put the science. Later other people also start from there. Now I'm tackling lung cancer and other problems. So this one here, now that you have the package, now give us another problem. Should I tell you the other problem? Mary, have you seen the TB report? You said you are going to reduce TB incidence. You have only achieved 25% of what you said you are going to achieve. So you have failed. 25, me as a teacher, is F what? F12. Eh? So as a whole world, we have failed. Have you seen that table? Winters, can you show them? No, the table you sent me, showing how we have failed in all the indicators. As a whole world. Of course, Uganda did well. We did well. We have cut mortality by 50% of TB. But the whole world has failed. So where is the problem? Did you set a wrong target, or you don't know what you are doing? Now I'm started thinking as an academic. So this is now the next problem. Why are we not moving on the targets we set? What is this organism that is defeating you people? And also you have to account, how much money have we given you? Since we set that target of 2030, and you have scored 12%. Now the parent is on the table. You have your report with your hand with your 25. Winters, please show that thing. Give it to those people. They think I'm joking. So what I'm trying to say, as academics, we are actually not interested in one thing. We have abilities to analyze and solve. So we are now going to move to the next what? The next problem. That could take us another 10 years. This one has taken us 15 years. So we need to start asking ourselves those questions. I will give an example. Rosemary, you are working on MDR. it has increased 3 times. Can you account what has happened? These are the questions we need to ask ourselves as we move forward. Yeah, you know. Eh? No, I've not disseminated. I'm just giving to bring it home. Eh? To bring it home. So we need to start asking ourselves these questions if we are going to move on what? On this TB thing. Yeah? And we need to really find out what is happening. So now, anyway, going back to post-TB, it is going to be part of our what? Of our care. Professor here is showing me the digital programs. I'm actually very interested. And you know, for me, these things actually, I try them on myself. Of course, I'm not a post-TB. Yes. In my clinical trials, I swallowed those drugs actually. One had actually killed me. This fluvoxamine, I didn't sleep the whole night. If people are going to swallow this thing for 6 months, why can't I try one dose and see what is happening? If really I want to sign them 20-page consent form saying they will take it for 6 months, I first take one dose myself and I see. Yes. Yes. So now, Prof has a digital platform. Now, Richard, your fear that the phones are not there, don't fear. Eh? Don't fear. You had my Proverbs Monday. If a cat wants to become a lion, it should lose its appetite for eating what? Rats. Don't start thinking we don't have the digital forms. Give us the digital platforms. Let people do PR on their phones inside their bedroom. And motivate. Now it brings me to Fanuel. So your man was doing his squats with the fruits. Malawi, you are not easy. So the results, are they from the fruits he ate or from the squats?
Thank you, Professor, for those highlights. Here we have a representative from Commissioner Clinical Services, has been with us since we started. Let me invite Dr. Emma to call him to give remarks. Discussing about.
Oh. Okay, I don't know which protocol you're following. Giving remarks, is it closing remarks or go? First go through it.
Yeah. We said we are going to reduce TB incidence by 50%. We got. Anyway, this one. So we really need to find out, and probably Mary and other TB programmers, we may need to reset the clock to really look, are we doing what we should be doing? Do we have the tools? Do we know what we are doing? Or are we setting wrong targets?
Did you pose a question? I was not following. Okay. So maybe someone will echo it to me. I didn't get him. I was M&E team is here. Okay. Can we go on? Thank you, Kasita, and all protocol observed. I think now we are into closing mode, if I'm not mistaken. I want to thank you, Director MLI, and your team for the good work you're doing. I want to thank my colleagues from NTLP, LPHS Director, Dr. Mary, thank you very much, and our TB survivors who may be here. From today's discussion this morning, I've learned a number of things. All facts have come out. Number one fact is that PTLD is a real problem. So as programs, or as a program, we need to go beyond just identifying cases and ensuring treatment success rates. Data is showing us that for some patients, TB is a lifetime disease, and they need to be helped. And I'm happy that pulmonary rehabilitation is the answer to most of these problems. Number two, whenever we go for meetings, our PS is always singing about integration, integration, integration. And as you've seen, once someone has a disability, he also has some other disease, comorbidities. So we cannot avoid integration in whatever we do. So integration is the only way to go if we are to help our patients. And we need to assess our patients at the earliest point possible. And the question people keep on asking, who is going to do the assessment, okay, and provide appropriate interventions, and is it feasible for us in our setting to do the assessment for these comorbidities? From the research findings, yes, it is possible. You can assess patients for comorbidities, for disability. And what we need to do as a ministry or as stakeholders, we need to build capacity, as we've heard. But most importantly, we need to have a low-cost pulmonary rehabilitation. I still emphasize, we need a low-cost pulmonary rehabilitation that can be done at the lowest possible level. We want to avoid patients coming from a distance and spending a lot of money, because distances actually lead to non-adherence. So if we can have community interventions, that I've seen Professor bringing up an app here, it is possible. The argument of saying our people do not have phones may not be so much valid. At least in a family, one person has got a phone, and that can be used for the patient. I don't want to take most of your time. In the ministry, we observe hierarchy so much. I'm the senior medical officer at NTLP, but I also have a principal medical officer representing Commissioner Clinical Services, Dr. Geoffrey Mogisha. Let me call him forward to come and make his remarks on behalf of the ministry. Thank you. Dr. Mogisha, you're very much welcome.
Thank you very much. The director and the team, Makerere Institute, our guests from abroad who managed to travel safely, invited guests, ladies and gentlemen, protocol observed. Good evening to you all. My name is Dr. Geoffrey Mogisha. I'm a principal medical officer in for the Commissioner Clinical Services Department. I want to thank you for having spared time to attend to this function from morning up to now. I see all of you are active, and I also want to thank Makerere Institute for having conducted this study to come up with these interventions which can help people who have chronic lung infections. Case management lies within the docket of Clinical Services Department, and pulmonary rehabilitation is essential and important to improve the health of clients who have developed post-TB complications. You are all aware that TB is not easy to treat. When I was doing internship in Masaka Regional Referral Hospital, I treated one of the patients, and after like 3 weeks, he came with similar symptoms mimicking TB. We did all the tests, they were negative. We did chest x-rays, we were confused. We gave another dose of TB. You see? But there was no improvement. So, for sure, we need to care for these people, and the only way to go is to integrate pulmonary rehabilitation in the existing care, such that it becomes routine in our settings. And this is possible because already we have chronic care clinics within general hospitals, regional referral hospitals, and at national level. already something is there. So what we need is advocacy. We need resources, and perhaps we work hand in hand with the Makerere Lung Institute to ensure that we build capacity for our healthcare workers to get knowledge and skills at national level. We can get TOTs, then we go to the subnational level, we train the regions and the districts. If we do that and we ensure that it becomes part of the routine care, it will mean that these patients will not suffer a lot. I will pass over the findings to my boss such that we can see the way forward. Thank you. I wish you the best.
Thank you, sir. I think we are coming to the end of this occasion. And before I call Professor Bruce to crown it all, I just want to take this opportunity to thank you all for being patient and attentive to whatever has been presented. I also want to thank the presenters, our partners from UK, Malawi, and local researchers. Thank you for the work well done. And also we take the opportunity also to thank the team that has made it to happen. This dissemination event happen, and to share with you what the findings were, and also looking forward on how it can influence interventions of people with PTLD, and as well as chronic respiratory diseases in general. The truth is those findings have been evidence, but also who are also in a clinical world, we have tried it in various multi-morbidity cases, and pulmonary rehab interventions work. So I understand there's a group photo provision, and it's after Professor's remarks, final remarks, and closing remarks at the same time that we go for group photo. On the program, if I'm not mistaken, I see cocktail here and the departure at leisure. And maybe Dr. Wins will throw more light on that one. Okay. Please, Professor, your closing remarks, please.
No, this one I have to put on my Richard, you don't know how directors we do our things. Now I've converted into the director again. I'm no longer a scientist. Anyway, good evening. I think I'm here just to give thanks to everyone. But before I do that, I don't know whether Professor leading the international team, if you may have any last words.
Now, I just wanted to say a huge thank you to the whole team that have been involved in the project. I think you've all battled through COVID and some of, lots of other challenges. So you have done the most amazing job. And I think, I feel as though you're on the crest of a wave now, because everybody in the room is so willing for this to work and move forwards, that hopefully meetings like this will give you the momentum to keep going forwards and really, provide rehabilitation, not only for people with post-TB lung disease, but, people that are multimorbid in the future as well. So I think as always, when you do research, there's lots of challenges around implementation and lots of new questions that you could ask as well. So I look forward to hearing how you proceed with your implementation strategies and how many people you can touch that struggle with post-TB lung disease. So thank you.
Okay, thank you, Prof. So I will also continue with the thanks. I want to thank our patients who participated in the study. We could not have done this trial without them. Yes, patients taking decisions to participate in studies is not easy. The second group, of course, the research team. Wincy and Richard and your team, please, thank you. Clap for them. It looks actually a small trial, but very, very intensive. Actually, you told me the largest PR trial is what? 50 patients? Less than 30 patients. So this was quite ambitious. These people worked very, very hard, even to identify qualifying patients. I think I was not here. I'm sure you saw in the screening algorithm how many people could not participate in the trial because of one reason or another. Of course, MRI management, we are always here to make sure that you do your work. In the morning, I said I'm a political scientist now, almost 50%. And when you're a leader, you are concerned with making other people's lives better. That's the primary, making sure that they have what they need to do their work. So we do that every day at MRI. Personally, I do 6 days, 7 to 8 p.m. Every week, to make sure that the different research groups within MRI are working. Of course, this has come at a cost. Some of my collaborators these days, they are worried. They are not seeing me. When I give them a favor, I say, work with this one. They say, no, Bruce is not there, he's not there. But finally, when the work is delivered, everyone is what? Is happy. I do that because I have also been supported when I was coming up by my seniors who were doing extremely hard work every day to make sure that we come up. It is now our time to make sure that people come up. Dr. Kotimang told me when he was retiring, you know, he gave me some of his things, but he didn't give me his clinic, he closed it. I thought I was going to be sitting in easy breath, but he knew I'm not that good at making money, so he's closed it. So he told me, the moment you reach 45, don't expect anything from anyone, but people expect you to be giving back. So that's what we are going through. So I have to say, Professor Sally, you are not the only one who is concerned. Will this study happen? I'm no longer seeing Bruce. Bruce is not here. There are about 40 research groups which are going through the same. But my aim is to transition leadership to these people. And I want you to clap for Wincy. He has delivered the trial. With me in the background. Actually, what my collaborators don't know, that I meet with these guys every week in a separate meeting where they are not. Every week, I meet with them. But in that one, I want you to be seeing their face. It's not easy. We have just completed an audit in the TB clinical trials. There was really no problem. The people could not accept that Joanne could lead this trial. So they said, let's audit these people. They audited us. But the trials are still going on. And now, I see they are becoming happy with the leadership of the TB clinical trials. Susan is back. So I want you guys to do your thing. Yes, you roll with it to whatever extent. Of course, when I'm not there, you will get the answers. So I thought I need to explain that. That is now the dispensation. With so many groups, all of them needing help, it is not easy. You can zoom and zoom. Yes. So I needed to mention that. So the research team, please, thank you so much. But grow, increase quality of work. This is for the emerging leaders, you know yourselves. Let me talk about IDI. IDI is one institution which has really transitioned from one generation to another, seamlessly. You see how they are moving. From the generation of Sewan Kambo to the next, to the generation of Andrew, now to the generation of the Marys, emerging leaders. This is what we want at MRI also. We don't want this thing which clings on one person. We cannot build institutions like that. Now, the next thing is to discuss a little bit what next after this clinical trial. Yeah? We want to plan probably an implementation rollout trial for pulmonary rehabilitation. We have the pilot, which is with the NTLP. So NTLP, when you are rolling out the next stage, please allow us to embed in an implementation rollout trial. Implementation science is also coming out as a very big component on how to make things effective. If we just go into full rollout mode, you will come back to us, clinical service, and say, your thing is not working. Yeah? We are going to stop it. It's a burden. It has collapsed the healthcare system. So that means after these clinical trials, we need to plan a rollout phase, implementation rollout phase, to give you more information of the likely problems which may happen with the intervention. This intervention here, as you've heard, is very impactful. You can actually help any person who is sick, yeah, in the hospitals. How are we going to do this? What will be the resources? What will be the impact? What if all your nurses in the morning are now excited, they are doing exercises and they are not given the ampicillin? What will happen? Yeah? So all these things, we do them in the implementation rollout phase. So we are going to work with our collaborators, Professor Sally and others, to see that we can plan this such that we give you something that is going to be useful. Finally, I want to thank the Malawi team for being here. Fanel, you are really very prolific. I wish I could steal you and bring you into MRI. You MRI science, do you see? This is how someone builds a story. Build a story from here, bring yourself to Kampala, take yourself back, go to UK, until when you become independent. So thank you so much. And Prof. Rimban, thank you for the mentorship. We really like to see people like this coming in what? In Africa. And I have told people before, please Africans, stop thinking that people think with the skin. We think with what? With a brain. People, the UK people don't listen to this. These people here, when they look at their skin, they now start delegating thinking. We don't want this anymore. The brain, from a black skin, a white skin, looks the same. But of course, don't be lazy. The color of the skin is a phenotypic characteristic, which has a relationship with a genetic characteristic. Yeah? But you don't know the direction of that relationship. We need to work hard. Please, I like people like you. I don't know how many people, young men like you, are in Malawi, but if you are like 20, very good. Huh? If people can work like that, tackle a problem from your heart and deal with it up to the end. This is actually the model that I want. I don't want these people who keep jumping, this jump to this one, jump. No, say, this is, I'm going to deal with this. And you really, really become a leader in that area. I think I will stop here. And thank you so much, and wish you safe travels wherever you are going. And to the collaborators, we really, really appreciate taking off time to come here and stay with us. Thank you.
Thank you. You know, room for improvement will never end. Always we shall improve. Kindly, Wincy, update us on that last issue. I am not very sure.
Yeah, the agenda is correct. We have a cocktail after here, and yeah, please let's network, mix and mingle, and departure is at leisure for sure. I mean, it's a. Oh, there's also tea. Some coffee as well. So, as you wait for the other things to be ready, you can be sipping on the tea. But really, just to again say that it's been a successful 2 days. For the people who have been with us from yesterday, you know how intense these activities have been, and I think it's a deserving way of ending a successful event. So please let's meet and talk a bit and chat and network a bit. Don't forget the group photo. Is it going to be here? Here? Okay. So we had one yesterday actually here. So we organized ourselves here, and then we let the sun shine on us while the picture was being taken. So I think we might do the same. And in case we need other, pictorials, we can take one down again. But I think we are going to organize. I don't know who's going to organize for that picture around here. Okay. Otherwise, yeah, we meet at the cocktail. Thank you. After the director has said, we can't say much apart from inviting you for the cocktail. All right. Yeah, also to thank Sky Gold that have done us good in making sure that we had steady internet, and the event was quite colorful with all the videography. Thank you. Yeah, thanks. All right, picture. Agaba. Okay. Agaba is going to organize us, and then we will take the picture.